then we can receive your questions. We'll then shift to just know more about muscle ultrasound and various neuromuscular disorder. And you will see in the program that we have a break, that we will have to take 2 breaks. So we'll take one break, a short break, 20 minutes after the first 3 talks. And then we have to stop at about 12. We will then continue our schedule, and we have to stop at 12 p.m. because here in Egypt and the Arab countries, it is a weekend, start of our weekend, and we have like a holy prayer at 12 p.m. So most of the people go to mosque to pray for about half an hour. So we have to stop to allow the participants living in these regions to just go to the prayer, and then so it will be a break for those who don't live in Egypt or Arab countries, and it will be a prayer time. And then we'll get back to continue with the last session about dynamic muscular ultrasound. So I expect that it's rich day, but I think the topics are all interesting. So we shall now start, and the screen is yours, Professor Natalie. Thank you.
Thank you very much. So good morning, everybody. So nice try. So I hope this time it's working. Yes. Okay, so good morning, everyone. I hope you had a great day yesterday because it was quite a very interesting ultrasound seminar. And now let's start day 2 with traumatic nerve injuries. As you all know, our high resolution ultrasound probes have improved immensely, so we are now able to see even small structures of the nerve. So here's an example of a median nerve in a cross-section view. Next to it, anatomic scheme, and we are able to see nearly all structures of interest. So, for example, the fascicles are the dark round structures here. You can easily detect all of them. At the distal part of the median nerve, there are a lot of fascicles. At the proximal part, there are not so much. They are dividing throughout the course of a nerve. What else can we see? We can see the tissue between the fascicles, the perineurium and the interfascicular epineurium. So all the white stuff between the dark round fascicles is connective tissue and surrounding tissue of the fascicles. And at least you can see the white line surrounding the nerve. It's the epineurium, the last structure of the nerve before the nerve is inside the other tissue, for example, muscle or what else. So quite a good view to start if anything is damaged inside the nerves. So traumatic nerve injuries are well studied from that part, how they can be divided histopathological. So there's no electrodiagnostic or ultrasound classification so far, but it's more from histopathological and anatomy studies made by Seddon and Sunderland more than 100 years ago, nearly. And Seddon divided nerve injuries into 3 parts: neuropraxia, axonotmesis, and neurotmesis, and Sunderland divided them into 5 classifications. He subdivided the axonotmesis into 3 groups, in contrast to Seddon, who just defined axonotmesis. And what does it mean? This classification is quite important for concerning the prognosis. So neuropraxia is believed to be just a conduction block where hardly any nerve structure is injured or damaged. So the potential of regeneration and getting completely healthy is very high. The next step, the axonotmesis, like the name already says, is a disruptive of the axons, so a more severe damage, but all the surrounding structures are conserved, so intact, so the axons are able to regrow inside this surrounding structure. Next step, all the surrounding structures are getting damaged, so it's more complicated for the axons to regrow and find the right path to regrow throughout the nerve. And I will later show you what happens if I don't find the way. And the last step is, of course, if the whole nerve is disrupted, so without any surgery, no healing is expected. So the first two are therefore not treated with any surgery treatment, but very conservative concerning the nerve. The other things, for example, fracture, of course, have to be operated or elsewhere get treated. So, and the last two are very clearly indications for surgery, and number three is somehow in between. So it can get very good without any intervention, but it also can develop a neuroma, so surgery is needed. So number three is somehow in between. And McKinnon defined a sixth classification, which I think is more common than the other one. It's a combination. So you won't always have just a conduction block or just an injury of one axon, but somehow several degrees of injuries within one nerve. That makes it more complicated to define and find right therapy, because there are several injury degrees and each degree needs maybe a different treatment. So I think number 6 is more common injury type and it's the most complicated one. To add something to the Sunderland classification, Milesi defined a classification of nerve fibrosis. So it's not at the time of injury, but during the course of recovery, what could happen. So there are 3 types of nerve fibrosis. Each type causes different problems and have different indications for surgery. So type A is the epifascicular epineurium, which is involved. So meaning it's the outer line structure that goes a little bit in between the fascicles. And if that is getting fibrotic, it can compress the nerve and lead to more severe damage. So the epineurium has to be removed, or at least the nerve has to get more space to recover properly. So, and this lesion is thought to be combined with a more minor lesion of Sunderland, so it's not in neurotmesis, for example. Type B is extending the fibrosis to more inner structures. So it's getting more complicated to release the nerve and to do some surgery, but it's even more important to do that because the fascicles can be compressed and axon damage and more fascicular damage can occur and the nerve won't recover. So in addition to the epinurectomy, which is done in type A, more internal structures have to be operated, and meaning the tissue surrounding the fascicles. So it's more in detail and more dissecting the nerve. And type C is even more damaging the nerve. It's the endoneurium structures surrounding the axonal and fascicular parts. So if these are getting fibrotic, the fascicles and axons as well will degenerate and no recovery can occur. So this resection is combined with all the other stuff. So you remove this part of a nerve to get a more space and release the fibrotic tissue and get the nerve to recover properly. So, what course of nerve recovery do we know as far as we can detect it by electrodiagnostics? So if you examine the patient immediately after trauma and do neurography, you will always see a complete or incomplete conduction block, meaning the loss of motor action amplitude, but you cannot distinguish between the lesions. So lesion 1 to lesion 5 will always be the same conduction block. So at the time of trauma, you cannot distinguish by electrodiagnostics what was happening to your nerve. Later, after 2 weeks to 3 weeks, you can see if there is any axonal loss happening because the loss of nerve action potential can be seen after this period, and you can detect degenerative by myography, and that has a certain reason. You all know that it's caused by a Wallerian degeneration, meaning if an axon is affected and injured, the distal part of the axon will degenerate and will not work properly, but that won't happen at once. The axon, the distal part, will degenerate during a certain period of time. So, and for the compound motor action potential amplitude, there was a study showing that more than 50% of the amplitude is reduced after day 3 to 5, and after day 9, if the axonal damage is high enough, no amplitude is normally seen. With sensory amplitudes, it's nearly the same. It takes a little bit more time to get to 0. So after about 1 week, you will have a loss of amplitude of more than 50%, seen here. And at around day 11 to 12, all the amplitudes will be gone. So that's for diagnosing axonotmesis after 2 or 3 weeks. No earlier detection is possible because of a Wallerian degeneration. If the nerve is healing, several steps in recovery are taking part. The first step is the partial axonotmesis, is the collateral sprouting, meaning if one axon is dissected, the neighboring axon will start sprouting out and innervating the muscle fibers normally innervated by the injured axon. So the neighboring axon will take care of the muscle fibers. That's collateral sprouting. But the injured axon, if not injured severely, cannot outgrow by about 1 millimeter per day and re-innervate the muscle fibers, because collateral sprouting will not manage to re-innervate the whole muscle that was lost. And this second re-innervation, depending on the length the nerve has to recover, is taking months. And if no or insufficient re-innervation is seen, you can say that it's a very high axonotmesis, grade 4, or even the nerve is dissected. But it takes months to recognize this high degree, because you always wait for the re-innervation potentials, and if they're not there, then is the step without any ultrasound or MRI to say, okay, it must be a higher degree of lesion. So if no proper recovery is happening, what is happening at the nerve? The axons try to outgrow, and if they don't have their defined structures where they know how to outgrow, they will grow diversely, and that will result in neuroma. And in literature and in classification, there's always a mix-up between neuroma and pseudoneuroma. So, and neuroma are the wrong axonal sprouting seen here. In upper left picture, for example, here is a stump neuroma after amputation or nerve dissection. Also can be seen if one part of a nerve is injured, a lateral neuroma where the axons outgrow laterally and not in the line of a nerve because the structure showing away is missing. And very controversially discussed is the neuroma in continuity, because there is some outgrow of axons in the right direction, but some are not outgrowing properly, and a lot of scar tissue, meaning collagen tissue, is causing this thickening of a nerve. And normally it's not a good prognosis if you have a neuroma in continuity, for example, in the brachial plexus. Normally you have to dissect this part and do a nerve graft to get a correct axonal outgrowth and get a good recovery. Pseudoneuroma, I think you all have seen one. For example, a Morton's neuroma is not a neuroma, but a pseudoneuroma. So at all compression entrapment site, like carpal tunnel or cubital tunnel, you see a thickening of a nerve proximal and sometimes distal to the entrapment site, and that's not a neuroma, but a pseudoneuroma, because it's a thickening of a nerve, but not wrong axonal outgrow, but a thickening of tissue, of scar tissue, of its edema, and not the typical neuroma where axonal sprouting is wrong. Okay, so what are our limitations with electrodiagnostics so far? So as I mentioned earlier, you cannot distinguish the Sunderland grades and cannot define your proper treatment, not after several weeks or months. So at the time of trauma, you have to be really patient without any ultrasound or MRI to distinguish your grades and to determine what lesion of a nerve is there. Mixed lesions are very difficult to detect because certain parts are different, and you will have some re-innervation and some muscles not. So that's another problem. Sunderland's 6 degree. If you use myography, the amount of spontaneous activity is no prognostic factor, so it won't help you. How good is the re-innervation? Do you have any time? And sometimes the exact localization of nerve trauma is very difficult and not so easy, especially if there is second lesion site, so you have no exact localization. And during the re-innervation phase, if anything is not healing properly, you don't know what is happening. Is there a neuroma, is there compression, is there fibrosis? So that's not possible to detect and to say more by electrodiagnostics. So that's why we have ultrasounds. It's one of the courses. And now I want to show you how these Sunderland degrees might look up in ultrasound. As I mentioned, they're not so easy to detect and say it's this lesion because it's a histopathological classification, and although the ultrasound has a very high resolution, you're not that high to say exactly that's the pathological anatomic structure which is affected. So, but you have some other hints saying what is happening to the nerve and getting you an idea what prognosis you might have. So in minor lesions, meaning Sunderland degree 1 or 2, you can see normally in normal fascicular structures For example, in the lower left picture, so you in the long axis you can see all the fascicles going through. Again, here you can distinguish between all fascicles, even here in the nerve swelling part, and say, okay, everything is in continuity, and the nerve is in total intact. And sometimes you see some nerve swelling of the fascicles, but they are intact and the structure itself is conserved. In Sunderland 2, so the more severe, the more gets the nerve swelling, and nerve swelling distal to the lesion is thought to be the correlation of Wallerian degeneration. So if you have a nerve swelling distal to the lesion, that's a sign of axonal damage. So we are now at degree 2 if you have any axonal damage and loss of axons, and that might give you a hint after a few weeks to months what lesion degree you have. And in degree number 2, you have still the fascicles intact, the structure is conserved, nothing is compressing the nerve. So lesion free, as I mentioned, is more tricky because it can get very good without any surgical intervention, but most of the time it's somehow in between. Re-innovation will happen, but not to the best outcome. So there always will be some paresis or anesthesia left in the worst case. So what could happen in Sunderland degree 3 is that you have the structures, most of the structures going through the nerve, but as you see here, there is some dark round structures around the fascicles making a nerve swelling. You would say that's a pseudoneuroma because all the fascicles going through as far as you can tell. And there's a thickening of surrounding tissue, meaning scar tissue, collagen tissue, maybe compressing the nerve. But if you have something like that, the prognosis is not that bad. In comparison to major lesions, meaning lesion 4 and 5 in Sunderland, the structure is completely different. So as you can see here, there are hardly any fascicles you can distinguish and say, okay, they're going through. It's very blurry. The echogenicity is not hypoechoic, but you have lighter areas, normally meaning scar tissue, and not so much hypoechoic fascicle structures as it would normally be. The nerve is swollen, distal to the side at the lesion site. You have problems in distinguishing the margins because it's so quite upswollen, and you can hardly tell if there's any structures, but you can tell that the nerve is in continuity and no nerve dissection is happening. So here's an example of a case report of a young male, 24 years old. He got a cut injury of the median ulnar nerve. The median nerve seen on the left side got no surgical intervention, and the ulnar nerve got a direct nerve repair, but there was no re-innervation in both nerves after 3 months. And what you could see in ultrasound is that you have in the median nerve this round structure with very high echogenicity, hardly any fascicles you can tell and distinguish. So that's mostly the correlation of a neuroma. And in the ulnar nerve, you see some fascicles going through. That's the direct nerve repair side, but you also have some parts which are round and very blurry, and in the cross-sectional part you can hardly distinguish any fascicles. So you have a neuroma here as a result of a cut injury, and you have nerve enlargement with just some fascicles going through here, so it's not a good result after surgery. Let's go to the last Sunderland degree, number 5, the dissection of the nerve. So you see here one part of a nerve in between some edema, but not nerve parts. And here the other part. If you wait a few weeks to months, you will get a stump neuroma at the distal and proximal sides. Here, for example, you can see some screws from the fracture surgical intervention underneath the nerve. So here again, there's no continuity of a nerve, but it has a gap in between them. And later on, it will get stump neuromas. In this case, it's important to also measure the length of the gap, because it's very important for the surgeon to know if a surrograft, for example, has to be done if more than 1 centimeter is in between, or if a direct nerve repair can be done if the gap is not wide enough, and if the ends of a nerve are cut bluntly and not with a, for example, a trauma that is causing a very blurry ending of the fascicles, meaning that you have to cut the end of the fascicles to get a more tight and clean site for direct nerve repair. Again, to just show you how big the nerves can get in Wallerian degeneration. So in this case, there was a motorcycle accident resulting in the paralysis of the complete arm. And that was because the brachial plexal roots were disrupted. So all the plexus is severely damaged and all the nerves were degenerating. And if you look at the nerves, you see, for example, the median nerve at the upper arm, a cross-section area of 30 square millimeters. Normally, it's the nerve just has a cross-section area of about 10, so it's 3 times the size, and the same with the ulnar nerve or radial nerve, they are enlarged as a sign of validation distal to the lesion site, and meaning that the nerve is dying. So the partial axonotmesis were very difficult. Sunderland 6 degree after McKinnon is not so easy to detect by ultrasound as well, but you might have some hints. For example, you see some free cross-sectional area. This picture on the right is at the lesion site, and you see in the lower part of the nerve some very intact fascicles. You can distinguish them, and in the upper part is a very blurry part where you don't have any idea are there any fascicles. And if you scan the nerve in the long axis, you see again that the fascicles in the lower part are more or less intact, and in the upper part you see the structures, which is a neuroma resulting from a partial nerve damage. Very lower part is nearly normal or just minor lesion degree injured, and the upper part is dissected and was resulting in a neuroma. So let's have a look at the nerve repair techniques. That's important to know if you control the surgery efforts. So the most common is the epidural approach, meaning you don't combine all the fascicles, but just attach the nerve at its outer structures, under the idea that the fascicles will find their way and the nerve will outgrow in the right direction, and you just have to get him the outer structures to regrow. Another approach is the fascicular repair, meaning you take the fascicle groups and attaching them. That's not so easy because you try to get the right fascicle groups together, which is not always possible, to define which group belongs to what other distal group. But all the fascicle groups, each by each, will be attached, and at the last part, the outer structure, the epidural, will be attached to. But there are none of the techniques is superior to the others. So the most easy approach is the epidural approach. And sometimes you use the fascicular repair. That's more convenient if you only have a partial lesion. You can also just do a partial fascicular repair, or also do just a fascicular nerve graft and not of a total nerve. And if the nerve is severely damaged and the gap is too far, you need a nerve graft. Normally you take the sural nerve, and it's like in the epidural or the fascicular approach at two sides, where you use the sural nerve as a nerve graft in between this gap, to get the axon grow through the graft inside the distal segment. So how does it look like in ultrasound? We have a lot of patients in control after nerve surgery, direct or nerve graft surgeries. And here is an example of a very good result. The best is to see it in long axis if all the fascicles are going through. So here is the attachment site. It normally gets a little bit bigger, and sometimes some neuroma will appear. That's normal, because not all axons will regrow properly, but some of them always will lead to a neuroma. So a thickening at the repair site is normal, but you can see the fascicles going through, and that's a good sign of recovery. And in cross-sectional view, you see the fascicles here. It's normal to have a more blurry view. It's not so clear as in a healthy nerve. But you can distinguish the fascicles, and distal to it, you also see the fascicles and not so much nerve swelling as in Wallerian degeneration. So that's a good sign of nerve repair. So I got you another example of a median nerve. So the scan will be from distal to proximal. The median nerve is located here. So we're going up, and that's the repair site. And now we're going to the distal side of it. So I will show it again. Here's the nerve, fascicle structures. That's the repair site. So that's the total cross-sectional size of a nerve with lots of fascicles you can distinguish. It's getting larger, a little bit blurry. That's normal at the repair site. And you have a normal fascicle structure later on. So, and you also will scan it not just in short axis, but in long axis as well. I think it's better to see if the fascicles are outgrowing. And if you just tilt your probe a little bit, you can see very well this good result of nerve repair. Okay, so you can use a nerve graft, as I showed you earlier, normally taken by the sural nerve. And sometimes a vein is wrapped around the nerve site to protect it, to get a more protecting structure around it, to get it supported by good surrounding and not the possibility to compress it and to slide it throughout the course of a nerve. So sometimes a vein graft is added as well. And how does it look like? You have to know it, because otherwise you're a little bit shocked seeing this large area, but most part of it is the vein surrounding and wrapped around the nerve to support the nerve, and the nerve graft itself is not that large as you thought it might be. Again, you see some good fascicular structures here as one sign of a good result. So next case I got for you, let's move up to the next Sunderland, is a 10-year-old girl. Some years ago, she unfortunately had a riding accident and broke her left arm at the upper segment and got an ulnar paresis, but most of the ulnar nerve was getting well again. Only the fifth muscle was missing reinnervation. And if you look at the ultrasound, that's a very interesting finding here. We are at the upper arm, not at the wrist or somewhere. That's the humeral bone. We have the triceps, and on top, very superficial, the ulnar nerve. So I will show you the video. So it's still normal, and now is the lesion site. The fascicular structures going very large and swelling. I will show it once again. And top, getting big, but still being in continuity. So, and these are fascicular neuroma. And one of them was severely damaged, so there was a fascicular nerve graft, and the girl recovered very good. So, but this case is a very good example of fascicular somatotopy. It's hardly discussed how the nerve is organized, if there's an early organization in regions, and or if there is a lot of intertwinement, and only in the later course of a nerve there is somatotopy. But as Professor Lieber-Samuel yesterday mentioned, there might be a very early fascicular somatotopy, so the fascicles are organized in the correct order. You can say in which area is for what muscle or for what skin touch sensation area responsible. And in this case, it's the picture from the study of the interosseous anterior syndrome, showing that not at the suspected lesion site at the lower arm, but at the upper arm level, there is inflammation of just a fascicular structure leading to a very distinct syndrome, the interosseous anterior syndrome, but showing there is always an inflammation at the same site, indicating that there is a very early fascicular somatotopy. So the nerve injury sites also give us some hints about the organization of a nerve, which is very important to know. If there is a lesion you suspect it to be distal, distally might be more proximal located because the fascicular structure being responsible for this muscle area is already somatotopic organized, and just this part is injured and being more proximal than you sometimes suspect. So in tubing, we try to find another parameters of prognosis by ultrasound, so that might help you in early distinguishment of a nerve degrees, and of course in helping you deciding if a prognosis without any surgical intervention is good, or to get you a better idea when to do intervention and at what criteria. So this was the first, the retrospective approach. We had more than 300 patients with focal traumatic nerve lesion. We had to exclude some of our patients because of other diseases we had earlier before the trauma. And we had several patients with a complete paralysis, meaning all muscles distal to the nerve injury were paraplegic. We had most of them got some degree of paresis, and some got just a partial paresis, meaning some muscles were intact and some muscles were paretic. So at first contact, that was not always after nerve trauma. We did ultrasound, and after 6 to 9 months, we did a checkup, and we measured cross-sectional area proximal and distal to the lesion site. At the lesion site, we calculate the amount of visible fascicles and also evaluated the surrounding tissue. Is anything compressing the nerve? Is anything hampering nerve regeneration? Is there a neuroma? So, and at least we got 152 patients who were included in our analysis. Duration of symptoms were mostly less than 8 weeks, and some patients were seen quite late because we weren't sent to us earlier. And we have several reasons of nerve injury, for example, fractures or cut injuries, but we also have iatrogenic reasons during, for example, surgical procedure, or we got a blunt trauma, which injured the nerve more severely and more diffusely. So, and we get a variety of nerves, the radial-median ulnar nerve, the peroneal nerve, and other nerves, mainly the brachial plexus, were analyzed. And we also correlated it with electrodiagnostics, meaning what does the myrography show? So in complete paralysis, no response, no voluntary activity was seen. And here in many patients, we only saw very low voluntary activity, only by some fibers, and in 15 patients, no response was seen. And in partial paresis, most of the patients showed activity and only one no response. And we did ultrasound, and we looked at the visible fascicles. We didn't count them, but we calculate how much of the cross-sectional area is covered with visible fascicles, and divided it into more than 50%, less than 50%, only 1 to 2 fascicles visible, and non-fascicles visible. CSA, meaning cross-section area at enlargement site, was measured, and enlargement was calculated using our normal values. So it's more than 100% of normal value, more than 200, 300, and 400, and 500. And here you can see the percentage of patients who improved clinically, not getting very healthy, totally healthy, but improvement was our criteria. And if you have a look at it, you see the more visible fascicles. So 50% is the line between a very good prognosis and poor to very low prognosis. And the cross-sectional area enlargement was as well a very important factor. So the larger the nerve adhesion side, the lower the prognosis. And of course, if cross-sectional area was enlarged distal to lesion site, meaning is a Valerian degeneration, meaning axonal loss and injury, the prognosis was less good, indicating that it was a more severe nerve damage. A very important fact as well is the surrounding tissue. Is there any scar tissue compressing the nerve, like in Milesi type A to C, as you already heard, hampering the nerve regeneration, or is there even a nerve torsion, which is normally seen in inflammation, but can also occur in after nerve trauma. So what else prognostic factors were analyzed? The Italian group of Luca Padua and Coracci analyzed the size of neuroma, and they stated that if neuroma size was more than 500%, for example, here seen here, it was always associated in their patient group with missing re-innovation, meaning more than 500% nerve enlargement with neuroma. The prognosis was very poor. If the size was less than 500%, as you can see here, the clinical improvement was very diverse. So some improved very good with a very good strength, and some stayed very poor with a complete paralysis. But it might be one hint if neuroma size is more than 500%. Another approach was by the group of Dr. Heinen from Oldenburg, and they analyzed the nerve echogenicity of nerve injuries semi-quantitatively, meaning they defined the region of interest, inverted the picture, so all black is now white, and vice versa, subtracted any background noise, and defined a threshold so that the picture is calculated into black and white parts in dependence of how black and white, how much black and white values we had before. And they defined a ratio between black and white areas. And they stated that if the more area is getting white, meaning black earlier, the better was the outcome. So they showed a semi-quantitative, quite interesting analysis, and showed that even after surgery, the nerve is getting better in echogenicity as a marker of a good prognosis. So what do we have for hints of a good prognosis? So in electrodiagnostics, you have conduction block and no pathological spontaneous activity after weeks, meaning no axonal loss. So that's the first hint for you to see that there's a Sunderland first degree part and apraxia, recovering completely. So if your sensory or motor amplitudes can be measured even after 14 days or 21 days, so the higher the amplitude stays, the better is the outcome. And in myography is how much voluntary activity you can have after re-innovation, showing you a good re-innovation process. In ultrasound, you see that the cross-sectional area at lesion sites is important, so less than 300%, and more than 50% of the area with visible fascicles is a good prognosis. And the Italian group showed that neuroma less than 500% are more in favor of a good prognosis, although some patients did not improve at all. And the Heinen group might get us a new technique in analyzing the nerve echogenicity and showing that a more hyperechoic nerve is associated maybe with more scar tissues, so more hypoechoic the nerve is, the better might be the prognosis. So next step is not to do ultrasound before a surgery, but also during surgery. So there are some good results and procedures by Maria Petro in Günzburg, who is doing ultrasound during her surgical procedures, which get you an much better idea of how many fascicles are at what length affected. So she's using a gel patch, lying it onto the nerve and placing her ultrasound probe above it and getting very nice pictures of a nerve. There was a study by Burks and his colleagues who compared ultrasound finding with histopathological analysis of transected nerve segments, and they showed a good result for the ultrasound. So you can see here some fascicular structures which you could distinguish before by ultrasound, and residing more in a neuroma, fibrous tissue, residing here in this blurry vision. And again, you get a fascicular idea in ultrasound as well as in anatomic studies. So there's a good overlap of ultrasound and histopathological findings. So it guides the surgeon to find the right site, what is happening to the fascicular, to the fascicles, if are they going through or are they injured, and what to operate. So that's a good help and a good technique to improve the outcome of a patient. So let's give you another example what might happen to the nerve, a nerve torsion, which is more common in inflammatory neuropathy, as Professor Liebesame told us yesterday. For example, after amyotrophic plexus inflammation, after some time, the inflammation is resulting in scar tissue, leading to nerve torsion. By ultrasound, how does it look like? You have the radial nerve here at the upper arm, so you see the humerus bone lying here, and just have a look what the nerve is doing. So I hope you can see. So, and you can see the nerve turning around itself. It's like a little bit like it's dancing. And now it's divided into its two terminal branches, the superficial and pin. So I will show it again. You see here it's twisting, turning around if you elevate your probe throughout the course of a nerve, getting you an idea of nerve torsion. And this has to be removed surgical because of a nerve torsion. All the vessels are compressed and the nerve is getting an infarction, so it will the nerve is getting to die and will result in complete loss of axons. So this tissue hampering the nerve has to be removed, and normally other sites in inflammation can be seen. So the surgeon will always look at other sites if there is not just one torsion, but another torsion site, the entwistment sites. So it's quite complicated to get all torsion sites, even especially in inflammation, where are several parts of a nerve torquated. Okay, so let's move to the last part of my talk, to the scanning protocol, what to scan, and the important question is when to scan. So there's a hard discussion on what to use, electrodiagnostics, ultrasound, MRI. So our protocol is to scan the nerve immediate after trauma if possible. Sometimes it's not possible because the injury is too severe to do any ultrasound scanning. And some authors recommend to do some electrodiagnostics, but you won't see anything that will help you, just to get an idea if there are older lesions before the nerve trauma, to keep in mind in evaluating the results weeks and months later. So, and the main questions for ultrasound, of course, is the nerve intact or is it dissected, meaning it can be surgical repaired? Is there anything compressing the nerve, for example, in fractures, some bones fractures, or any surgical osteosynthetic material, or is the nerve intact and you can wait for recovery? After 3 weeks is the first point where electrodiagnostic is important, because you can detect axonal damage by using myography. So if there is no signs of axonal damage, meaning pathological spontaneous activity, you can say it's neuropraxia and will get a very good recovery within 3 to 4 months. Or if is there any hint to axonotmesis? And if you combine this examination with ultrasound, you get a good idea of the nerve itself. Is there only one lesion? Is there a second injury? Is anything hampering the nerve recovery? Is there more severe damage? Is there any severe nerve swelling? So you, after 3 weeks, combining these two techniques, you get a good impression what is wrong with your nerve. After 6 weeks to 3 months, you just want to check how good is the re-innovation. Of course, you clinically examine the patient, how good is recovery, but you also do, of course, electrodiagnostics, and this part is myography, the most important part, because it's showing you, is there any re-innovation at the very proximal lying muscles, or is it missing, and that indicates you there might be something wrong with your nerve. And after 3 months or even 6 weeks, you can say, is there a minor or major lesion? Is the cross-sectional area enlarged? Is there distal enlargement indicating a more severe damage? Or is there even developing a neuroma indicating that the nerve recovery is not complete but hampered? And if you have signs of re-innervation and the patient is recovering and you have no other hints in ultrasound, you wait for further recovery. If you have no re-innervation or anything in ultrasound, neuroma, or indicating some Sunderland 6 mixed lesions with dissected fascicles, you can already do some surgery procedure, meaning nerve graft, fascicular graft, or direct nerve repair, or neurolysis if any fibrotic material is hampering the nerve. But if re-innervation is good, you wait until the next 3 months. There's another decision point. Is the re-innervation in time, meaning 1 millimeter per day, nerve outgrow reaching the more distal lying muscles? So you check again by electrodiagnostics. Is the nerve recovering in time? Is it a good result for this time? Or is, again, anything hampering the nerve, meaning neuroma and maybe a second lesion site? So if re-innervation is very poor and recovery is hampered, surgical procedure just to have a look at the nerve is recommended. Otherwise, you wait again and control the patient in 3 to 6 months to see if the recovery is going well or not. So, and the scan protocol is always to scan in short and long axis to get a good idea of the fascicular structures. And if possible, you scan the whole course of a nerve. Maybe there's a lesion more proximal to the suspected lesion site, or is there a second lesion, a double crush injury, or is there entrapment hampering the nerve? And entrapment sites are an important topic because even if the patient had no entrapment before, during nerve recovery, it might hamper the nerve recovery because the nerve is getting swollen due to Wallerian degeneration. The nerve is recovering and might be entrapped at entrapment sites, for example, the cubital tunnel for the ulnar nerve or the carpal tunnel for the median nerve. So our surgeons tend to release the entrapment, possible entrapment sites is there if there are any near injury sites and they are doing surgical procedure, they also release the entrapment to get a better nerve recovery. So it's recommended to scan the entrapment sites as well to get the idea if anything's hampering the nerve recovery. So, and here's an example of an entrapment, in this case of a posterior interosseous nerve, the motor branch of radial nerve, and normally it's very compressed and very small going throughout the supinator muscle, but here you can see it's very enlarged. And the long axis, you see that it's getting swollen. And for the radial nerve, we suspected that this is a site where the nerve is very tight and heavy to this entrapment site, and it might be that there is a humeral fracture injuring the nerve, and sometimes you see very early a second lesion site or this entrapment site as a hamper of a nerve recovery because it's getting swollen and not everything from blood flow is going through properly because of the entrapment and incision of a nerve. So You scan proximal and distally to the lesion sites. This will get you an impression of possible prognostic factors, meaning if the nerve is swollen distal to lesion, it gives you an idea of Valerian degeneration and of axonal loss. So the prognosis is not as good as in neuropraxia, of course. At the lesion site, are the fascicles going through, or is there anything damaging them? How many fascicles can be seen? 50% of a cross-sectional area or less. You measure the cross-sectional area because the larger the area, the larger the nerve enlargement, the poorer might be the prognosis. You look at the echogenicity. Is there hyperechoic areas, so indicating new fibrosis? Is there anything indicating for a neuroma? And of course, you look at the tissue around the nerve. Is there a lot of scar tissue, bone fragments, osteosynthetic material compressing or hampering the nerve? So concerning this point, I got two examples for you. First example is of a young girl who broke her arm at the upper arm segment right next to the elbow. And you see here this bone spine that is getting in touch with the median nerve, and you see the fascicle structure is not visible here. It's getting distal to the side, is already getting swollen, so it's enlarged. And this indicates you that this bone fragment is compressing the nerve at this site. So it helps the surgeon to have a look, and surgery procedure was done, and this segment had to be removed, and a sewer nerve graft had to be installed because no nerve action potential was going through, and the nerve was severely damaged. Another example is seen on the right side. It's the radial nerve at the distal part of the humerus after a fracture. And what you see here is that there's something going above the nerve. It's a screw that it's very very going outside the bone, and the nerve is going underneath it and getting hampered by the screw. So another example of getting your view to the surrounding tissue. This is a case of an 84-year-old male patient who got treated by Marcoma warfarin. So the blood is very thin, and he tends to get a lot of hematoma. So he had a mild trauma to the right arm, and bleeding got into the muscle, leading to these quite big hematomas seen here in the upper arm segment, more than 4 centimeters in depth and nearly 3 centimeters in diameter. And the nerve itself got swollen due to this compression of the hematoma more proximally. Here is a musculocutaneous nerve with 5 square millimeters. Normally it's about 2. And even the median nerve, which can be seen here, is swollen with 16 square millimeters. Normally you get 10. So these are distal points to the lesion site. And although it was a mild trauma, there was a severe compression due to hematoma of the brachial plexus and some nerve segments, leading to paresis and this nerve findings. So, and another hint to look more properly after surgical interventions. This was a very young patient, 21 years old, with an elbow fracture. which was surgical intervented. And after surgery, he complained about anesthesia of the last two fingers, and the movement of the fingers could not be examined because due to other injuries. So we had a scan of our ulnar nerve. I got a video for you. So it's the elbow part, and here will be the ulnar nerve, that's scar tissue. But let's first have a look at the surrounding tissue. So you can see a lot of things here. For example, this is the flexor carpi ulnar muscle, and you see that the echo texture of the muscle is not normal. It's very got very hyperechoic areas, indicating trauma and edema of the muscles. And the skin, you see, if you pay attention, you see some dark areas, meaning there's fluid inside the skin, as a hint for you that it's swollen and full of edema. So, but let's have a look at the nerve. So here it will be. Here. It's not the best video, I have to say, I'm sorry. Okay, so, and I will show you some things at this example. First of all, I will start again. So let's stop here. So if you have a further look at the nerve, you see the surrounding tissue and epineurial structures are very light, indicating scar tissue surrounding the nerve. Just one point you see the fascicles appear hypoechoic, but a little bit enlarged. It might be normal at the cubital tunnel because it's compression site for the nerve, where it's in most of us it's alterated due to the cubital tunnel and the elbow movements. So let's have a further look. So now for a second, the cross-sectional diameter is getting low, it's getting very thin. I hope I can get to it to you again here. So, and if you scan it in long axis, you see that the nerve itself is compressed by scar tissue, and before and after this scar lesion, the nerve is very swollen. It's got a very light epineural structure, indicating that it's collagen fibrotic tissue that is hampering the ulnar nerve. So that gives you an impression that the recovery might be not good. So it is a hint to surgical treatment. So another example of having a look around the nerve and at the nerve. Again, a very young patient, 19 years old, with a knife injury at the right forearm. He pinched himself accidentally, and he got a very large hematoma of a superficial flexor muscle seen here. So we got these dark areas indicating hematoma. And you see the median nerve, who is already swollen with some hypoechoic areas. And in the long axis, you see that there's a discontinuity. A very large hypoechoic area might indicating, for example, hematoma, and no visible fascicular structures. Maybe at this side, you see a few fascicles, which might be intact, but most of them are not going through. So this is an example of early detection of severe nerve trauma, where you don't have to wait 3 months to get the right diagnosis. So another example one of the last examples, I think. So this was a patient with a forearm fracture, which was surgical, intervened with a fixator externe, so a screw was gotten into the radial bone, and you see here the superficial radial nerve, and let's follow it throughout its course. So, sorry, here, once again. Yeah, wait. Okay, so you see the nerve here getting divided, and now you see the old lesion site of a screw that has already been removed and how it is hampering the nerve. I will show it once again. This time I hope I can stop here. Again, sorry. And now you see the scar tissue right next to the nerve, indicating that the screw was punched next to the nerve, affecting the nerve. If you scan it in a long axis view, I will show you the video. Here is the screw scar. Again, so this part is with discontinued fascicles, and most of the other fascicles are going through. Okay, that was my last example, and I thank you for your attention, and I hope I got you a good overview of traumatic nerve injury ultrasound. So thank you very much.
Ollie. Okay, can you hear me? Okay,
Yeah,
sorry.
now.
Yeah, thank you so much for this amazing talk. Really, it's really amazing, conclusive, impressive talk. I really enjoyed it, and the examples are great, just great. So I think we have many questions related to this topic, of course, because it's really interesting topic, and it usually raises many questions. So we can start see the questions.
Okay, first question I see is how to differentiate between a neuroma, pseudoneuroma, and external scar entrapping a nerve. So neuroma and pseudoneuroma is a very good question. So normally in nerve injury, I would refer to as a neuroma because axons are not outgrowing properly, but leading to a neuroma, a very difficult to diagnose neuroma type is the neuroma in discontinuity. So some axons are going through, some leading to neuronal formation, and there's a lot of scar tissue. So if you have any indication that the fascicles are stopping and leading into a bulb, that's your indication for a neuroma. And if the nerve is just swollen or there's a lot of scar tissue inside the nerve, it's more referred to as a pseudoneuroma. And normally you can see the nerve margins, which help you in the differentiation between external and internal scar tissue. So that's one differentiation. And if external scar entrapping the nerve, it's not nerve enlargement, but a reduction in diameter, a little bit similar to entrapments. Okay, I hope this answers your questions. So next question is, with nerve lesion, distal degeneration occurs. So in nerve repair, how can we see good nerve fascicles in distal part before seeing them in repaired area? So that's, let me think about it, how you meant your question. So in nerve repair, how can we see good nerve in distal part? So that's not so easy to see, you're right. Normally the distal fascicles are looking good. You can distinguish them. They might be swollen. But that's the part for the electrodiagnostics. So you shall have a look if there is any re-innervation, and you, after nerve repair, you more control if any fascicles are going through your repair site, or if there's a large neuroma, which indicates that it's not a good result. So you're right, in nerve repair, the distal part is not so much important in this prognostic fact. So where will help you with electrodiagnostics. Next questions is for measuring cross-sectional area to prognosticate an injury, where to measure the normal nerve diameter proximally or distally. The better it would be to get the proximal side, and we always use the healthy side for comparison, because there might be that your proximal lesion site might be affected as well, but it is more rare than distally, because if there is axonal loss and a distal nerve swelling is happening, it will swell throughout the whole course of a nerve if you wait a long time. So distally might be the point where you never get a normal nerve diameter. So we always use the other healthy side. And if that's not possible, why, whatever reason, you have, I would choose the proximal side a lot of centimeters far from the injury site. Do you use ultrasound to guide EMG needle in apparently clinical paretic muscles? For other diagnostic diseases, we use that, but in nerve injury, we clinically examine them, and we use some standard muscles. First, the very proximal located muscles to nerve lesion, and very distally. And of course, we scan them by ultrasound. Can you see any movement? Is the muscle fibrotic, or is it still intact? But normally, I don't use ultrasound to guide the myograph needle. I just use it in other diseases, for example, myositis, to get to the right place, but in this case not, but of course you could do that. What are limitations of ultrasound in traumatic nerve lesions? So the first limitation is, of course, immediate after trauma. So if there is a large edema and it's then, for example, open fractures, you might hardly see anything. So that might be a problem as well. In contrast to MRI, who has problems with animal material, which is can be more common. And the next limitations of ultrasound is, of course, you cannot scan all the nerves. If they're too deep, you have some problems. For example, sciatic nerves can be very difficult to see if they're lying very deep. So that's your limitations. And of course, you get an idea how the nerve looks, but not how it functions. So you always combine electrodiagnostics with ultrasound. What is the role of Doppler ultrasound in cases of neuroma? So as far as I know, there are not so much studies, because it's not like neurofibroma or schwannoma. There might be an enlarged vascularization, but in neuroma, it's mainly scar tissue and axonal tissue. So as far as I know, there's not so much role for ultrasound, for Doppler ultrasound. But you can also use it for the other parts of the nerve, indicating you some regeneration process, and sometimes might be an indication for an additional inflammation. Does hydrodissection, dextrose and corticosteroid have any place in the management of adhesions? Also, is there a role of PRP platelet-derived growth factor? So as far as I have to admit, I'm not so familiar with the anatomical platelet-derived growth factor studies. Of course, there are studies looking for a better nerve regenerations. There were some studies with some fibro glue to get the nerve attached, but it was showed not as good results as, for example, direct nerve repair. And as far as I know, corticosteroids and anything to dissect adhesion is not used in our clinic, but I have to admit I'm not so familiar with this techniques. Next question is, can we differentiate the prognosis of nerve injury according to ultrasound study? So I tried to show you some indications, but there are missing ultrasound studies to confirm our hypothesis of prognostic factors. So the ultrasound alone is not sufficient to get you all the prognostic things you might want to have. Is it important to comment upon the content of a nerve ends which are separated and due to nerve trauma? Yes, that's a very good question, because it is important for the surgeon. So I will try to give a measurement of healthy segment to healthy segment, so the surgeon knows the gap he has to, for example, use for a nerve graft, or if direct nerve repair is still possible. And if the nerve is dissected, the surgeon will have a look at the nerve, but it's a good thing to comment on the nerve endings. It helps a lot the surgeon. Okay, so next question is, I notice you are using an ultrasound scan 24 megahertz. Yeah, that's right. And are you using a software for filter and something the image which made image lose information? So normally, yes, we use 24 megahertz. If there are any deeper structures, we use the 18 ultrasound megahertz probe. And we do not use any distinct software. So from software company and ultrasound company to another, we already have a software on your device. And sometimes it's not a good contrast, so you have some adjustments to make. At first we had some problems because I didn't like the pictures because they are very blurry and contrast was missing, but there's no specific software filter we use, so we try to use the main attachment of ultrasound device, but sometimes it's necessary to get in contact with a company to get a better resolution and contrast of your pictures. In case nerve conduction study reveals no response, but ultrasound reveals continuous, however, hypoechoic nerve, how should we interpret that? So nerve conduction study is very very difficult because it might reveal no response, and the prognosis might be good although there is no response. So the main thing we use for in electrodiagnostic for prognosis is myography. Is there any re-innovation or not? So if there's re-innovation, some signal has to go through. And although we always do nerve conduction study, the main prognostic factor is myography. And myography and ultrasound is some very good combination. So if a nerve conduction study does not show any signal, but ultrasound gives you a good impression of a nerve, I would trust the ultrasound and do, of course, myography as another important factor. Okay, next question. Any role of elastography to diagnose isolated fascicular injury apart from T2 MRI signal? I'm not quite a fan of elastography because the area is too small to really distinguish all elastographic stiffness points. There are some studies giving you some hints about the stiffness and about possible prognostic factors. But maybe the others have other opinions, but I'm very skeptic about elastography as a good prognostic factor. Is there any Doppler parameter useful to define severity? As far as I know, there's no good study about it. So the nerve enlargement and visible fascicles are more important. Is ultrasound superior to electrodiagnostics immediately after nerve injury? Yes, it is, because immediately after nerve injury, electrodiagnostic gives you hardly any information, because independent from nerve lesion, you will always get a complete or incomplete conduction plaque. In myography is not possible because it's too early to detect axonal loss and spontaneous activity. So ultrasound is superior immediate after nerve trauma.
Okay, great. Thank you, Dr. Natalie. Thank you so much again for the very nice lecture. And we shall now move to the next lecture about the muscle ultrasound in various neuromuscular disorder. So, Professor Doris, the screen is yours. Sorry for that, there are some delay in the program, but we will catch. But I think the interaction part is really very important, so I did not want to interrupt this. So, the screen is yours, Professor Doris. Thank you.
So, good morning, everybody. And thank you to Professor Winter for the great talk and the great discussion. I'm now allowed to talk about muscle ultrasound in various neuromuscular disorders. So you all visited the basic course, so you heard a lot about the technique, especially from Nils van Alphen. And today we will just have a look what it does look like in the different disorders. So we'll just start a little bit more general. Let's see what or how you can actually include imaging into your workup of neuromuscular disease. Well, of course, first and foremost, you have your clinical findings, which will show you which will guide you the way. But from there on, imaging can be of help. You can, of course, something like demonstrate or objectify the clinical findings if you find, if you see something like a change in echogenicity in imaging. It can help you to find the best place for your electrodiagnostic testing, and it can show you where actually you best do your muscle biopsy to get a positive result. And finally, also by defining there is a pathology, and also by sorting out the pathology a little, you might get hints into which direction you have to go with your genetic testing. So as I already said, you can use it for defining or objectifying the presence of pathology. You define a pattern. And what we are also starting out at the moment is monitoring of progression. So there are studies that show a progressive decline over time now. And as there are new treatments on the horizon, it will also get very interesting about response to treatment. Which imaging tools do we have at our hands? Well, we all here, of course, think that ultrasound is the greatest of all, but to be honest, also MRI is doing a really great job in that field, while computed tomography is having something like a minor role when it comes to muscular disorders. For MRI, you can use so T1 and T2, most widely used. Diffusion weighted imaging can help you just to quantify your changes. And for whole body MRI, this is just something very specialized. I'll show you in a minute. So here are examples of normal findings on the left in T1 sequences, while in muscular disorders, you will get those fatty infiltration that will be hyper intense in T1. T2, on the other hand, is sensitive for fluid. So here on the left, again, the normal appearance, while on the right, you can detect the edema-like changes that you can find in myopathies. And here just an image of whole body MRI. I mean, this is great to really define a pattern throughout the body, but as you can see, this really requires a lot of specialized technique and also compliance from the patient. MRI rating scales were established or were suggested, a variety. Basically, all of them work with normal, mild, moderate to severe, and with just visual rating. The advantages of MRI, especially compared to ultrasound, I think first and foremost is, of course, that you get a totally clear cut right through the body. You see the deep and the superficial muscles in totally equal, perfect quality, yeah? Which might become difficult with ultrasound, especially if you are examining more proximal muscles. You might be limited with assessing the deep muscles. MRI is, of course, not really operator dependent. It gives you an excellent contrast, as you have seen, between the healthy and the diseased muscle. With one area, you can get quite large areas you can assess without having to sort out each muscle on its own. Also here, we try to quantitate, and there is new functional imaging on the way that will also look for muscle metabolism. The limitations of MRI are surely that it does not really allow dynamic assessment. So like in muscle ultrasound, we will have a talk later by Professor Tafik. We can, of course, also see movement within the muscle that is pathologically. In children, you will need sedation. It is at high cost, and it is, of course, not everywhere available. And I think whole body MRI you saw is something for specialized situations. Computed tomography, just a short side mention. I think the one and only reason you can think of it is actually that you can see calcifications better than in MRI. It would be more available and usually and works faster than MRI, so you don't need any sedation. But of course, it also comes with ionizing radiation. So this is not a really superior role in these cases. But now we turn to our main hero, so the muscle ultrasound. The history of muscle ultrasound, let's just take a short step back. One of the very first studies was published in 1982. Heckmat et al., so this is an important name you just keep in mind, told us almost 40 years ago that there were striking changes in children with neuromuscular disease, in the dystrophies. They saw an increase in the intensity of the echo in the spinal muscular atrophy as well. So the history is quite long, even longer than compared to nerve ultrasound, where the first publications of the median nerve at the carpal tunnel came out in the late 80s, I think 1988. But somehow from then on, the two modalities took a different development. While there is really a lot of research going on in the field of nerve ultrasound, somehow muscle ultrasound did not develop that fast. And there was a survey in 2018 where actually 19 specialists on neuromuscular ultrasound were interviewed how often they use ultrasound in workup of neuromuscular disorders. And you see here, so not seen at the center, these are the numbers that never see any patients in this indication. And the black column are those who use the muscle ultrasound ever during the diagnostic process. And the gray or light gray columns are those who use ultrasound first. So if you see here, also the specialists would only use it in around half of the cases. But why is it like that? Well, we can speculate about it. There was not that much research, so there are not as well-defined sonographic criteria. There is still a lack of familiarity among the physicians and also a lack of the familiarity of evidence that is available. And overall, there is less evidence. And you have to take into account many variables. So while in nerve ultrasound, it is mainly you having a look at the course of the nerve and looking for something like a change of caliber in, I think, around 90% of the cases. In muscle ultrasound, you have many factors you have to take care of. Okay, just a short reminder, what are the morphologic changes that we are actually looking for? So first and foremost, the change in the muscle morphology. So you're looking for an abnormal echotexture of the muscle. Second, sometimes you will also find abnormal thickness. So there can be atrophy, like I showed you yesterday, the neurogenic atrophy, and sometimes there could be hypertrophy or pseudohypertrophy. You might look for abnormal movement, like you can see the video here on the right, which shows you fasciculations in motor neuron disease. You will look out if there's anything of like an increased blood flow, which is, however, also not so easy to judge in the ending because we don't really have parameters for that as well. And you can then also look for the pattern of structural changes, so which muscles are affected throughout the body. How does the image, or why does the image change when there is a neuromuscular disorder? Well, normal muscle mainly consists of muscle cells, and in between you will have some fibrous tissue, some of the fascia, which is the main reflecting component when it comes to your ultrasound image. So here we have a muscle in longitudinal view, and so we would get actually those black lines and the white lines from the reflection of the fibrous tissue in between. If the muscle is now diseased and there is some fatty infiltration going on, that image will change because the fat will also reflect the muscle beam. You will get a lot of your beam back and the muscle will appear whiter on your image. The second thing that will happen is that, of course, your ultrasound beam gets attenuated at a much higher level, and less ultrasound beam is actually proceeding to the deeper areas, which makes it harder for you to see underlying structures. So, just some comments about the technique. First thing is the right angle. Sorry, I have the videos here, so I don't see it all down here. So, the importance of the right angle, just to see. So, if you put the probe in right into 90 degrees, okay, actually all the ultrasound that is sent out by your probe will get back and produce you the image. So, this is the best reflection you can get. If you're actually tilting the probe by just a little bit, so it was 5 degrees in that case, you will miss some of the ultrasound beam that is reflected because it just passes by your probe and not getting back directly. And this will then lead to deflection and, as you can see, change of the image. So you need to be careful about that. Then, the importance of the standardized settings. Whenever you do muscle ultrasound, you should actually get your settings into a preset so that you are sure you always look the same. Because on the pictures you see here, these are two different probes. And in the second image of each probe, there is actually the time gain compensation increased. So you get something like a depth dependent gain, yeah, increase. And you also see that this dramatically alters the appearance of the ultrasound images and also of how bright they are. And as muscle ultrasound is working with calculation of actually how much the intermediate gray value is, this will change your calculations. So always choose the right settings. I think it's not so important which you choose, yeah, but the important thing is that you always use the same ones. Then we want to grade it. The HECMAT, yes, this is the HECMAT from before, suggested something. I would like the quick and easy approach. It is just a visual rating. You can see here. And so grade 1 is like you have a normal echo intensity. You get that so-called starry night image. So you have the muscle fibers black, you have the fibrous tissue bright white, and you get a good reflection of the underlying bone and interosseous membrane in that case. If it, from then onwards, the muscle changes to brighter, yeah, and now there are different degrees of brightness, which are all not only defined by the whiteness you see of the muscle, but also with the underlying structure. So here you would already see an increased echo intensity, but you can still make out the bone really well. In grade 3, you see, well, this is whiter, yes, but surely not so easy if you only see this patient and decide, is it a grade 2 or a grade 3? But in this case, you see, you will have difficulties to make out the bone, while in grade 4, you only get one blurry image overall. So this is a purely visual assessment and grading. It is, of course, operator dependent, very operator dependent. Always in muscle ultrasound, also dependent on the system that you use. And the sensitivity is about 70%, we know. So if you just grade it visually, you will get the right ones with 70% of the time. Then there is quantitative muscle ultrasound, or I would say the hard way, but not in a negative way, because I think it's also the very academic way. This now works with the grayscale. So you have here the histograms from 0 to 255, from black to white, all the different shades of gray you see in here. You define your area of interest, which will usually be the cross-sectional area of the muscle without the fascia, because this is very bright. And then you take the image offline and put it into analysis, for example, with Photoshop or ImageJ, and then get a mean gray value. And I'm sure you can see that the mean gray value in this image is different from this one. So the difficult thing here is that you have to compare it to reference values. And this is always something that is just a sentence. But I think what makes up the immense, tremendous amount of work in this case, yeah? Needing your own reference values for each probe you use or machine you use means that you have to define a reference population, which should at least have 10 people of each decade. You would like to examine 5 male, 5 female, to get an idea what it does look like in normal people, and calculations you did with this population can then be your own reference values. So neuromuscular disorders have best been defined in children, and especially at Nijmegen. So Professor Van Alphen and Professor Pillen did a tremendous amount of work that really forms the basis of our work with neuromuscular ultrasound. Let's look at some fundamentals. So presence and absence of neuromuscular disorders. How good and bad are we with? It's always quantitative muscle ultrasound we are now talking about, okay? Actually, muscle ultrasound can differentiate between neuromuscular and non-neuromuscular disorders, yeah, with a sensitivity of 90 to a specificity of 90%. So these are really, really good testing parameters if you're doing it right. How do you define? Actually, if you have muscles, at least 3 or 4, so this is also a very short protocol, 4 muscles, I'll show them later. And 3 of them are at least 0.9 standard deviations above the normal in your grayscale analysis. Then you get those sensitivity and specificity. The negative predictive value is also very high, which means that you would get those who are sick, and the presence of neuromuscular disorder is highly unlikely if you have a normal ultrasound. So when normal muscle ultrasound is found, actually you have a very low chance that the histology will be abnormal, and therefore you could even prevent invasive procedures in children. So if you are seeing children with suspected neuromuscular disease, you could use your neuromuscular ultrasound for screening, yes, and if you find actually changes, then you could continue also on the basis of what you have found in ultrasound. Here are the muscles I talked about. So the protocol that would be used includes only 4 muscles, and of course it makes sense to take 1 proximal, 1 distal from each limb. Okay, then differentiating, what about if it comes to differentiating neuropathy from myopathy? Well, we have different patterns of involvement. In, for example, polyneuropathy, you would find your most striking changes, of course, more distally. So these are also quantitative muscle ultrasound changes, and you see above 3 standard deviations actually in the tibialis anterior, while compared to this, the arms are not or very little affected. On the other hand, if you have something like a dermatomyositis, which would primarily affect the proximal muscles, the image would just turn around. So you have the greatest amount of fractions in your proximal muscles, for example, here the quadriceps or the biceps. So these cards can then also help you to define. This is this pattern analysis I talked about, if you should rather think about dealing with a neuropathy or a myopathy. Yes, and another hint besides the pattern analysis is, I think you saw yesterday, so the neurogenic atrophy. I think this is really the most distinct feature you can use, because the atrophy is something that would classically appear in the neurogenic disorders. Also then in the advanced cases of myopathy, but when it comes to the stage of diagnosing, you would find atrophy and those increased hyperechogenicity more in the neurogenic disorders, which is more like inhomogeneous. I'll show you later on. So while you get a bright white muscle all over in the myopathies, it's rather like those patchy changes within neurogenic disorders. So yes, you see here, we are not really getting that high again. So positive with predictive value, we are getting those who are sick with 86%, and we are getting those right who are not sick with 84%. Of course, this is more difficult than just screening for presence or absence of a disorder. Now, what about the different myopathies we can see? So the most classical image is actually those of Duchenne's muscular dystrophy. And this is also the image I showed you before. So what you will mainly get here is rather bright white muscles. While on the next image, we already have the spinal muscle atrophy, so a motor neuron disease. And what you can see here is actually we have dark areas next to very bright areas within the same muscle. So dark, and bright areas within one muscle. And this is actually that inhomogeneous pattern we talked about. You also heard the term moth-eaten pattern several times during this course, if I'm right. And this is actually what would guide you towards a neurogenic disorder. In inflammatory myopathies, the different kinds, here we well, what also makes it difficult for us to change them, to diagnose them with EMG, the same is then depicted in ultrasound. What we see here are patchy changes. So you have here normal muscle next, so you have here something like a very dark muscle next to a rather, already a little bit atrophic looking muscle, while here you have even something that could look like an edema. And with inflammation going on, you could also find this increased Doppler echo. But you have to be careful with this because, as Nils already said in the basic course, already activating the muscles will change your vascularity. And therefore, this is not a very secure marker you can use. Yeah. So in dermatomyositis, there's one thing that I would like to show you. So in chronic disease, you will have those calcifications within the muscle, which of course give a quite typical image for you with ultrasound, because you have this bright reflecting structure from the calcification, and you are having a dorsal acoustic shadow. So this is something that is really good to see. Inclusion body myositis. Inclusion body myositis primarily affecting the long finger flexors, then also the quadriceps and the tibialis anterior. There was something described as very typical because the long finger flexor, like the flexor digitorum profundus, looking very atrophic on this image. Yeah, and if you have a look above to the flexor carpi ulnaris, you see that this muscle is well preserved compared to the underlying one. But this is just suggestive and not really diagnostic. Okay, keep this in mind. And also here you see you have very focused muscle involvement. So the gastrocnemius is already very atrophic, while the soleus is looking rather good. And also here the biceps completely atrophic, while the brachialis is not looking that bad. So look out for patterns. And if it fits the clinical description, I would describe it. Then this is something very, very, very special, but it gives a great ultrasound image, so I mention it. So Bethlehem myopathy is actually a limb girdle myopathy. And what happens here is, if you see here the quadriceps, you see that there is usually a central fascia, and in the case of Bethleham's myopathy, the fascia, so the disease progress will happen from the fascia inwards, and this creates something like a cloud within your muscle. So it's a very distinct feature, but it's very rare. So when it comes now to scanning muscles, just look which muscles are affection. Is it an inhomogeneous or rather a homogeneous change? If there is some inhomogeneity within your muscle, then look out first for the moth-eaten appearance, which would get you towards the motor neuron diseases. That inside-out pattern in Bethleham's myopathy, if you see one, that's great. And if you have those focal areas within the muscle, maybe also showing some kind of edema, then you could actually suspect inflammatory myopathy. Here, I don't want you really to walk through this. Yeah, the important thing is down here, because this leads you to Sigrid Pillen's thesis, and actually in there you will have all pathways that were built on all of their studies. How you would actually screen, yes, and how to then continue. So just see this. So 4 muscles is really not a lot to screen. And then how much is this above your mean gray value? And then this gives you clearly abnormal, borderline abnormal, or normal. And just to see, you can see this is also for differentiating neuropathies and myopathies, with some calculations inside that work with proximal and distal and versus leg, and also flowcharts for working up floppy infants, including all the lab screening. So you got really a lot of information there, yeah, that will help you. So finally, I would like to show you what is on the horizon. So this is a rather recent publication from April in this year. And there is now something like a check out how good is ultrasound also during the course of their disease, and will we then be able to hopefully use it for screening, for monitoring the disease. So this is actually work that is just going on. And to sum up, muscle ultrasound is a lot about technique. Yeah. The most important point is define your protocol and then stick to it. There is a lot of work that has already been done. So my recommendation is here. And also very important, I think, start out with clear cases. So if you are working with neuromuscular disorders, take those that have already been diagnosed and have a look at all of them, because this really helps you then to define what is normal and what is abnormal for the next cases. Okay, So I hope that was okay, and I thank you for your attention, and I'm open to questions.
Thank you. Thank you so much, Professor Doris, for this great, concise lecture. So we have some time for a few questions before we start our break. So I think there are 3 questions here.
Yes. Does the neuromuscular differentiate acute from chronic myopathies or acquired and hereditary myopathies? I don't know, acute from chronic. So I would say the longer standing the disease, the more distinct the findings are. Yeah. So if you're saying, because acute, I think this is also something you could sort out clinically. Because with hereditary, you would mostly see at the children's clinic. Yeah. Acute forms, I would say, are rather the inflammatory myopathy. So this would lead you to the findings I showed you before. So that patchy changes, yeah, maybe an increase in vascularity. And yes, I hope that answers your question. How can we detect tissue? Sorry, how can we detect
Disuse muscle atrophy? How can we detect diffuse muscle atrophy by ultrasound?
Okay, it looks the same. Yeah,
yeah.
It's of course not that pronounced. Yeah, but disuse muscle atrophy will be a neurogenic atrophy in most of the cases, right? Or like after stroke, so after a central system disorder. Yes, it will take longer, of course, because in that case the first motor neuron is affected, but there will be changes over time. Also with secondary degeneration of the second motor neuron. Yeah. So in SMA, is there any studies about effect of Spinraza on the change of the muscles? Not yet, I think. Yes, I'm not aware of one that is out, but of course this is very, very interesting. Yeah. If a heterogeneous muscle pattern seen without atrophy is myopathy, but does not rule out a neuropathy. What's the time period to result in muscle atrophy due to nerve lesion? Okay, let's start off heterogeneous without atrophy. Yes, then yes, right? We suspect rather a myopathy, that's right. But does not outrule a neuropathy. Depends on how early you see the patient. Yeah, the time period I said yesterday is about 2 months, so you can be sure to see actually the muscle belly diminishing in the affected muscles. Yeah, I think you will barely ever get into the situation where you have the problem that you see the patient that early. Okay, so. With acute changes, no, 2 months after, no problem. Okay. Does musculoskeletal ultrasound differ after exercise? Yes, actually the vascularity is increased, yeah, but the structure itself is not really changed. Yeah. Is there a role of neuromuscular ultrasound for follow-up of cases of myositis? Well, we are not really that good. We would scan them again, of course, but it's not like I could say from the ultrasound, we are that sensitive that we can now really say, okay, this disease process has really stopped. Yeah, so ultrasound is not the perfect tool for monitoring in this case. Okay. So thank you so much. Can studies in SMA depends on grayscale to see improvement with treatment, and how many normal children to take to depend on results and age range. Studies on, yes, you see improvement. Well, this is what we are looking for to get demonstrated in studies. How many normal children? Okay, so usually with children, it's a little bit of a problem because they change very quickly. Yeah, for the adults, it's per decade 10. Yeah, for the children, I'm aware of studies that used about 10 children for every 2 years. Okay. Pudendal nerve lesions leads to muscle atrophy in the muscle supplied. Yes, but to be honest, I did not change out. So for pudendal nerve, I use ultrasound only for nerve blocking. So sorry, no real experience with that besides blocking. Also for actually demonstrating that it really is a pudendal neuropathy. I think clinically this is not always that clear. What about ultrasound of neck and paraspinal muscles? Yes, this is just what has not been used in the studies. Yeah, I think the bigger role for neck and paraspinal muscles may be in the motor neuron diseases. And here, just like in the limb muscles, you will see the fasciculations with a much higher sensitivity than with the EMG because you can scan a lot of a bigger area. Yeah.
Okay, great. Thank you, Professor Doris. Thank you.
Thank you so much.
Yeah, I think we are done with the questions. Now it's time for a short break for 20 minutes. I kindly ask you to get back to us at 10:30 sharp, or even 1 minute before it to start 10:30 to be able to catch our schedule. Okay, thank you. So break time till 10:30. Thank you.
돌 때 뭐 청진기라든지 아니면은 진찰만으로 되게 이제 환자의 상태를 파악을 하는데 이제 그 정도로는 환자의 상태 변화를 파악하는데 좀 한계가 있습니다.
이 기계는 간단하고 간편한 기계지만 그 응급 현장에서 그 전송이 빨리 될 수 있었고 화질도 선명하고 로딩.
분만실에서 진통을 하고 있는 산모에게 쉽게 적용을 할 수 있게 되어 산모의 진통 상황이나 응급 상황을 신속히 파악하고 치료할 수 있게 되어 앞으로의 활용도가 클 것으로 생각합니다. 의료 혜택을
받기가 힘든 곳에서 저희 초음파를 활용한다면 통신망 등을 통해서 이미지를 전송할 수도 있고 다른 종합병원 등에서도 이미지를 판독을 해서 적절한 치료를 수행할 수도 있습니다. 그래서 앞으로 저희 초음파를 활용한다면 많은 곳에서 의료 서비스를 줄 것이라고 기대하고 있습니다.
And thank you for your patience and waiting for the questions. So please, do you have, if you do have any other question, please take them to the discussion, because now we have Professor Dr. George Broen again from Netherlands telling us about artifacts and defaults, which is very important, because when you interpret the sonographic picture, or rather the movie you're seeing, you should be aware not to misinterpret. You're not to misinterpret.
The suprapatellar recess. This is the standard longitudinal scan. So what we have to see at the scan, I will freeze the image. So we have to see first.
سنة 13 كانت
فقط العضلية يشوف تكنيكال
Okay, welcome back everyone. Sorry it was a short break, but we'll have a longer break later on. We just have to catch the program to be able to finish some of the lectures before the prayer time at 12. So next, we shall now listen to Professor Natalie. She will talk about the nerve ultrasound in generalized neuromuscular disorders. So Professor Natalie, the screen is yours.
Okay. So it's saying the host has to give me the permission to share the screen. Can you do anything about it? So
I'll make you a co-host, Natalie, first.
Okay.
Now you can share, okay?
Ah, great, thank you. And so now, perfect. So great, so thanks again. Let's start with the next topic, nerve ultrasound in generalized nerve disorders, which is quite a very interesting topic to discuss with. So as you all know, high resolution ultrasound probe developed so much that we now distinguish nearly all structures of the nerves and got a very high resolution of under 1 millimeter, so 0.2 millimeter as an axonal resolution and lateral 0.15 millimeters with regular available probes. So that's a great improvement. And so now we're able to examine all parts of the nerve to get us more information about polyneuropathies and what's happening with the nerve. So what do we scan and look at? So the main parameter is still the cross-sectional area. Is the nerve enlarged or is it normal? You can also examine the cross-sectional area of a nerve fascicle. So both total nerve and fascicle area is an important factor. Vascularization is more important in, for example, vasculitis, so immune-mediated neuropathies. And at last you examine echogenicity, either by looking at it in classifying it into iso, hyper, or hypoechoic, or you can do a grayscale histogram analysis by using, for example, ImageJ to get a more objective evaluation of your echogenicity. So it is recommended that each ultrasound lab got its own reference values, normal values, but there are several groups already publishing a lot of reference values for nearly all peripheral nerves. And if you have a look at the MRI studies, you see on the right side, you can see that by corresponding ultrasound and MRI cross-sectional area values, so we get a good corresponding thing here, and several groups for normal values. So as I mentioned before, cross-sectional area is one of the most important parameters in evaluating polyneuropathies. And first step is to see if the nerve is enlarged or if not. And in most cases, it's nerve enlargement can be seen in demyelinating neuropathies. That might be a hereditary course, like in Charcot-Marie-Tooth type 1A patients, or in immune-mediated acquired neuropathies, for example, CIDP. In both groups, you can detect nerve enlargement. In contrast to demyelinating neuropathies, axonal neuropathies tend to have normal CSA values, but I will show you two exceptions where ultrasound and electrodiagnostic helps you a lot in diagnosing the right axonal neuropathy. If you compare in demyelinating neuropathies the nerve conduction velocity and the cross-sectional area, you see that it's correlating inversely, meaning the larger the nerve, the slower the conduction. But please keep in mind that won't say anything about the clinical status of a patient. So the nerve can be very large, but the patient can be nearly paresis free. So keep that in mind that it's correlating, but it's not correlating with clinical status. So there are many polyneuropathies and many causes leading to neuropathies, and in green are marked the types that might lead to nerve enlargement in polyneuropathies. I don't want to explain all this diagram, just to give you an impression that it's quite a lot where nerve enlargement can occur, and that gives us some trouble. So how can we distinguish between these polyneuropathies, axonal demyelinating, what nerve enlargement and which polyneuropathy? So that's a question some other groups already discussed and addressed. And one group of Luca Padua from Italy got an excellent idea into classification polyneuropathies into 3 groups. So, and he stated there is a group that shows focal nerve enlargement, nearly normal nerve segments in between or just mild enlarged next to more enlarged segments. In contrast, you find total nerve enlargement throughout the whole course of a nerve, or you find no nerve enlargement at all. And he stated that focal nerve enlargement with a focus on some site is more common in inflammatory neuropathies, whereas in hereditary neuropathies, nerve enlargement is seen throughout the nerve. And in degeneration or axonal neuropathies, no nerve enlargement is seen. So let's have a look at the first group, the inflammatory neuropathies, and the best examined group of these immune-mediated neuropathies are CIDP patients. And there are a lot of studies showing us that nerve enlargement occurs in 90% of the patient. That can be either moderate to middle enlarged nerve to severe enlarged nerves up to more than 100 square millimeters, as you can see here in the of a median nerve of the forearm. So that's quite a huge enlargement. And nerve enlargement is not randomly enlarged everywhere, but it's focused on the proximal nerve segments, meaning the plexus, the brachial plexus. In MRI studies, you can also see enlargement of the lumbar plexus and, of course, of proximal arm nerve segments. There's a good study by Hode and his colleagues showing that the brachial plexus and the upper arm median nerve segments are significantly enlarged in contrast to other immune-mediated neuropathies like the multifocal motor neuropathy, or in degenerative diseases like amyotrophic lateral sclerosis, or in contrast to normal population. So if you combine median nerve and brachial plexus measurements, you get a very good sensitivity and specificity to diagnose CIDP among this group. And if you have a look at disease course, you see that there are some changes in nerves. And for the first part of disease course, it's thought that there is a hypertrophic remodeling, meaning that in acute, very early detective CIDP, nerve enlargement can be seen, and throughout disease course, nerves tend to get larger. But you can also have a look with ultrasound concerning your therapy. Not all nerves are just getting larger. Here's an example of a CIDP patient. For here, you get a very swollen fascicle. The cervical root number 6 is enlarged in diameter. And if you treat this patient successfully and the patient is improving, you can see that in ultrasound as well. So the diameter is reducing and the cross-sectional area of the nerve is getting smaller and tend to get normal, not more normal again. So all nerves won't get normal, but they tend to get smaller. And if the patient is getting worse or treatment is not working well, you can also see a decrease in diameter or in cross-sectional area as well. So the change is corresponding well with ultrasound finding. A next step is to classify CIDP patients concerning echogenicity, and Luca Padua and Professor Grimm stated that there might be 3 classes of CIDP patient. Class number 1, hypoechoic, meaning dark fascicles and nerve enlargement. Class 2, hyper, meaning more light fascicles and severe nerve enlargement, and class 3, no nerve enlargement. And if you have a look at therapy naive group, very early at disease stage, you see that most of the patients can be sorted out in class 1 or class 2, meaning enlarged nerves with either low or high echogenicity. If you have a look at more older patients during a later phase of disease, more chronic, you see there is a change from class 1 to class 2 and even to class 3. So there might be a shift in classes, and if the disease is somehow burned out, no therapy is working, it might be some effect that it's like burning out and just being fibrotic fibers rather than edema. If you have a look, if these classes give you an impression how your therapy might work, you see that in the class 1 and 2, there is the most improvement. So the upper part is improvement or staying the same in comparison to not enlarged nerves. If you see the electrophysiological change, it's somehow in both directions, but more to the improvement side, and ultrasound shows the most improvement for class 1 and 2 and nearly no change for the class 3, stating that this group of CIDP patient might not profit from therapy. We also correlated histopathological findings from biopsies with our ultrasound finding and could show that in class 1 patient, you can see the typical appearance of CIDP nerves with onion bulbs as re and demyelination. You have a lot of inflammation and edema and not so much axonal damage. That's changing in class 2. You get more axonal damage, but still signs of inflammation. And in group number 3, you have mostly axonal damage. So stating that class 3 might be fibrotic tissue and not so much inflammation, which you can do therapy with EVICs or corticosteroids. So let's go to the more acute immune-mediated neuropathies, for example, the Guillain-Barré syndrome. where you can see in the first day of disease onset an enlargement of roots and the vagus nerve, which can be sometimes early when electrodiagnostic alterations. You have hardly any other nerve enlargement, sometimes in proximal arm segments, but mostly in roots and vagus nerve. Here is an example of typical ultrasound findings of a cervical roots number 6 before therapy and after therapy. And this is in good correlation to our idea of disease pathomechanism with endoneural edema mostly localized in the nerve roots. And this edema is getting better under therapy, so the diameter cross-sectional area is getting better. There was a study proving that patients who clinically improved also improved in ultrasound diagnostics. So the diameter is getting normal again. The cross-sectional area of the vagus nerve is getting to a more normal value again after a period of about 6 months, stating that your therapy is in a good direction. So in multifocal motor neuropathy, it's a little bit different when in CIDP or Guillain-Barré syndrome, because it's more focally enlarged. So you don't have nerve swelling so much. You can find them, but the key finding is that you have some fascicles which are enlarged. And ultrasound is helping you a lot in differentiating multifocal motor neuropathy from motor neuron diseases, because at the early stages of both diseases, they can sometimes be very difficult to distinguish. And so ultrasound helps you if you have findings in nerve enlargement. You have an indication of an immune-mediated neuropathy rather than a motor neuron disease. So if you have a look at the fascicles, you see them focally enlarged. Mostly they can be found in the median nerve, and they correlate in more than 80% of the cases with conduction block findings in electrodiagnostic studies. So let's move on to our next group of nerve enlargement, and that is the hereditary neuropathies. What are with these? Is it correct that throughout the whole course of a nerve, nerve enlargement can be seen? So Schreiber and her group from Halle did a very nice study concerning this. So they examined a lot of patients with different hereditary neuropathies, showing that the most nerve enlargement can be seen in CMT1A patients, followed by CMT1B. And in hereditary neuropathy with pressure pulses, normal nerves can be detected or only mild nerve enlargement, which is a good correlation of our idea that nerve enlargement is mostly seen at the entrapment sites, and that's where the most nerve damage is happening. And in axonal hereditary neuropathies, like in acquired axonal neuropathies, like the diabetic ones, you see hardly any nerve enlargement in Charcot-Marie-Tooth hereditary neuropathies. So this was also examined by Luca Padua, showing in CMT1 patients the most nerve enlargement, followed by CMT4 and CMT X patients, so the demyelinating ones, and the axonal hereditary neuropathies showing nearly no nerve enlargement at all. So what about the axonal neuropathies? I promised you to show you 2 examples where ultrasound might help you in differentiating axonal neuropathies. One example is an acquired neuropathy vasculitis. Here is an example by Dr. Schelle, who showed that there is a focal nerve enlargement very long throughout the whole nerve, and normally you can see a higher vascularization. And in a study by Takao et al., he could show that in most of the patients, nerve enlargement can be seen, which is not that high, but moderate and focally restricted. So you see some segments that are enlarged and the others are normal. Nerve echogenicity might be increased, but that's not one main point. So you have this focal nerve enlargement, maybe a higher echogenicity to get you the idea that you have an axonal neuropathy and focal enlargement that might give you the hint to a vasculitis. And the next example for a typical axonal neuropathy, in this case, a hereditary one with TTR-related amyloidosis, also show nerve enlargement. So in a study, you see nerve enlargement nearly throughout all nerves, focused, of course, on entrapment sites like the ulnar nerve at the cubital tunnel, the median nerve at the carpal tunnel. But you can also see that at the proximal segments of the median nerves, more than in 50% nerve enlargement can be seen. And here is an example of a median nerve, the upper arm segment, where the nerve is enlarged with 15 square millimeters. And if you compare the different disease stages, you see that the more effective the patient is, the higher the disease stage, the more the nerve enlargement is, can be seen. So the nerves tend to get larger throughout disease stage. So the carriers tend to have normal nerves. Stage 1 already showed increased diameter of cervical roots or of, for example, the median upper arm nerve segment. So again, combine electrodiagnostics with axonal findings, with ultrasound, with focal nerve enlargement, that gives you a hint of maybe other causes of diseases like vasculitis or TTR-related amyloidosis. So many groups also try to do a scoring system to help you differentiate all the neuropathy types. One of them is Craig Zeidman from Washington, who stated that in CMT1 patient, nerve enlargement is more diffuse, meaning like Luca Padio stated, throughout the whole nerve course. In contrast, in CIDP patients, you also can see regional or mild nerve enlargement. Our next scoring system is that of Professor Grimm, who examines several points and evaluates the cross-sectional area. For enlargement more than 100%, you give 1 point, for more than 150%, 2 points. So you can score up to a maximum of 22 points. And it's quite a large setup, but you got very mixed nerves, sensory motor nerves, you get the brachial plexus, and also have pure sensory nerves like the superficial radial nerve, the superficial peroneal nerve, and the sural nerve. And if you use the scoring system, first step was if it can differentiate between acute and chronic immune-mediated neuropathies, and it got a good sensitivity and specificity for differentiating Guillain-Barré syndrome and CIDP from axonal and vasculited neuropathies. So you got a first impression how much points you get in what area. You can go through the setup and get an idea what might be your polyneuropathy. And we compared it with several other entities like immune-mediated CIDP, Guillain-Barré, or MMM, to vasculited axonal neuropathies 1, to hereditary or other acquired polyneuropathies. And you see that in CMT1A, you get the most nerve alteration and nerve enlargement, and throughout all points of measurement. And in CIDP, you see more focus on the cervical roots and the sensory motor segments. So that helps you a lot in differentiating the polyneuropathies. So next step, I mentioned it before, is the focal nerve enlargement versus total nerve enlargement. And there was another scoring system or idea. So you compare the nerve enlargement, again, give several points. If all segments of a nerve are enlarged, you get the most points. If just one segment is enlarged, just lower points. And that helps you in differentiating CIDP from inheritary demyelinating neuropathies. Here you see throughout the whole course nerve enlargement, and on the right side, CIDP patient with proximal dominant nerve enlargement and nearly normal nerves in the distal segments. Comparing these, CIDP and CMT1A, you get a very good sensitivity and specificity using the scoring system. Last part is not to evaluate the total cross-sectional area, but also fascicle enlargement. So first we defined cutoff values for different nerves of and different fascicle sizes to get an idea how large is it okay for a fascicle to be, compared it to CMT1A, and for example multifocal motor neuropathy, to get an impression of if there is any fascicular enlargement and a fascicle enlargement pattern. And we stated that there might be 3 or 4 fascicle patterns. The first one is you have no nerve enlargement and all fascicles are normal. And the next 2 is that you have a regional nerve enlargement where in some nerves fascicles are enlarged. In other nerves, no fascicle enlargement can be seen. Or you have a large fascicle next to normal fascicles. And the last pattern is all fascicles are enlarged, like for example in CMT1A. And the idea is that in these 2 groups are more the immune-mediated neuropathies, and this is the last group is more common for hereditary neuropathies. So what do we know? So in demyelinating neuropathies, we normally tend to see nerve enlargement. In axonal ones, regular not. I showed you the vasculitis and TTR-related amyloidosis as exceptions. In CIDP, nerve enlargement is more in proximal segments, localized, giving you an idea that it's an immune-mediated neuropathy. And in multifocal motor neuropathy or Lewis-Summers syndrome, it's more fascicle nerve enlargement, regional localization, giving you another hint of an immune-mediated neuropathy. In Guillain-Barré syndrome, mainly roots and vagus nerves are enlarged and getting better under therapy, and enlargement can be sometimes seen before alteration of electrodiagnostics. And as I mentioned, in vasculitis or TTR-related amyloidosis, you can see some focal mild nerve enlargement. So that's it for my talk. This time I stayed in time and I'm happy to answer your questions.
Yeah, thank you. Thank you so much, Professor Natalie, for this interesting talk. Yeah, you can have some questions for the next 5 minutes. So I think there's one here.
Yeah.
I think the first one is directed to Dr. Doris, Professor Doris.
Yeah, so I would just answer the second one, I think.
Okay.
I would like to ask, in Guillain-Barré syndromes, what are the measurements that determine the enlargement of roots, as it is bilateral? So that's where you have your normal reference values, either yours from your lab, or you can use the publicated reference values. That helps you get an idea if it's bilateral. That's the reason you need normal values.
Okay. Okay. Can you answer the question that Professor Doris?
Yes, of course. No, there is no study that the muscle structure is changing that much. That was just a suggestion from the studies that are out here. So I'm not aware of anything specific.
And next question is, do we get nerve root enlargement of cervical root 7 in neurogenic thoracic outlet syndrome? It's an entrapment syndrome, so you can sometimes see nerve enlargement of C8 or the first thoracical root if there is an entrapment, but sometimes you cannot see no nerve enlargement. But like in entrapment scores, there can be some changes in diameter. So thank you very much. For chronic neuropathies, diabetic, vasculitis, others, when treated, will ultrasound features return to normal findings, or will there still remnant of each pathology? So in Guillain-Barré syndromes, they can get normal again. So they can get to normal reference values. In CIDP, they tend to be still a remnant of pathology. And in diabetic neuropathies, even under good therapy, there are still changes in nerve alterations that won't cure completely. So you will see the alterations in diabetic ones as it's ongoing throughout the whole disease course. Next question, can we measure on ultrasounds? So that's, I don't understand what you want to measure.
I think this was the second part of the question about the C7 roots. So I think he's asking if we can measure the C7 root in ultrasound. I think so.
Yeah, I think so too. If you got a thin patient.
Yeah.
Is there any explanation for the enlarged cross-section area in axonal neuropathy in vasculitis or amyloidosis? As it seems, rare observation compared to other axonal neuropathies. So in vasculitis, it's an inflammation and edema leading to nerve enlargement, and in TTR-related amyloidosis, it's the amyloid plaques that are getting larger throughout the disease course. So that's different from other hereditary or immune-mediated neuropathies because there are products that the nerve can't handle that cause nerve enlargement. So in vasculitis, it's edema. and getting better under therapy. And in amyloidosis, it's amyloid plaque. So next question is, in clinical practice, when do we perform ultrasound for neuromuscular disease? As in most cases, nerve conduction studies and myography is usually diagnostic. And usually physicians do not refer patients for neuromuscular ultrasound, I would suggest. I would say,
I think she means new and neuromuscular. Yeah,
I think so too. So myography is just telling you if there is myographic or neurographic changes of a muscle, but it won't help you so much in defining what type of muscular disease you have. And ultrasound is one more hint that lead to the right diagnosis. And the next thing is many muscular diseases start during childhood, and doing nerve conduction studies and myography in children can be very difficult because it's very painful. And that's why many studies are ultrasound studies are done in children, because it's not hurting them and gives you a lot of information of what is happening with the muscles. Next question, how easy to detect roots versus cervical or lumbar sacral plexus using ultrasound for Guillain-Barré syndrome? So unfortunately, you only have access to the cervical, so the brachial plexus, and it's enough to scan, for example, the cervical root 5 and 6, which are easily accessible even in more obese patients, which tend to get difficult imaging, but C5 and 6 are easy to measure. So that's very easy done, and the vagus nerve next to the artery can be easily found and measured. So these three are a good start for Guillain-Barré syndrome. So do elastography have role in differentiating different pathology of peripheral nerve or differentiate between fascicular pattern? Again, I'm very sorry, I'm still very critic about elastography. And there are not so much studies dealing with this part in CIDP patients, for example. And I still think the methods is good for muscular changes, but the nerve area is too small, in my opinion, to get a good elastic stiffness impression. But maybe other groups tend to have a other opinion. So what about ultrasound of facial nerve, whether in traumatic injuries or other neuropathies? So I only knew some studies of traumatic injuries, post-surgical interventions of a facial nerve, and you get a small area where you can scan it, and it's getting larger, like in other nerves with Wallerian degeneration, but it's not so easy to scan the facial nerve. And for other neuropathies, I don't know any studies dealing with a facial nerve. So next question, how much of cross-section area or diameter variation among nerve roots is normal between left and right side? So I only know our studies, which tend to have diversity of 20 to 30% variation among nerve roots. As far as I know, the other studies showed the same, about 10%. So there is a variation.
Okay, okay, great. I think we are done with the questions. So thank you, Professor Natalie. And if you have any other questions related to any other topics, I think we'll shall postpone it to the end of the day, so we will be able to catch So I think we should just go on with the program. So next I'm going to talk about the important branches of main nerves of the upper limb and less common nerves. And I think you are stuck with me till the end of the course. Sorry about that, because we had to shift the lectures to suit Professor Antonion's schedule. So I had to shift to my lectures today. So let me share the screen once again. Okay, can you see me the presentation? Hear me well? Okay, can you take a conference confirm that you can see that screen? Can anyone confirm that you can see the screen and you hear me well? Okay. Professor Doris, can you just tell me that you can see? I can need confirmation if you can see my presentation. Something wrong with the presentation. Just give me 1 minute to start. So I don't have any conflicts of interest to declare related to this course or to the lecture. General educational objective of the intermediate level course is just to focus on the uncommon nerves. In the basic course, we have focused on the main trunk of the main nerves, but now we have to have a look on other important Antonians and Professor Natalie have talked about the prenerve branches and uncommon nerves of the lower limb. And now it is time to learning objective is to identify the anatomy of the less common upper limb nerves, to identify the scanning techniques and of the less common and as well as the common branches of the main nerve. So we will focus here in this talk on the palmar cutaneous branch of the median nerve, dorsal ulnar cutaneous nerve, terminal branches of the ulnar nerve, musculocutaneous nerve, and medial antebrachial. And this is extracted from the curriculum of the guidelines. So this, from the expert's opinion, this is what we should know in the intermediate level neuromuscular ultrasound course. And for each nerve, I'll start to speak about the anatomy because it is the key for tracing, the anatomical variations, if any. So no, anatomy is really important. We'll focus just a hint on the common causes of injury, indications for neuromuscular ultrasound scanning for these tiny nerves, and just a few examples of sonographic abnormality. So let's start with the palmar cutaneous branch of the median nerve. As you know, the median nerve arises by a lateral cord and lateral root and medial root from the brachial plexus, and then it descends, as we said in the basic course, it descends along the lateral aspect of the axillary artery, and then at the level of the midfoot, till the level of the cubital fossa, and then it will continue its way along the mid-forearm down to the carpal tunnel. And the branches that arise from the median nerve include, of course, the anterior interosseous nerve, which arises from the nerve just distal about the branch, the last collateral branch arising from the median nerve, which is the palmar cutaneous branch. So this is the main trunk of the median nerve, and the palmar cutaneous branch actually arises from the median nerve at the distal third of the forearm, at the level where the median nerve comes from under the surface of the flexus dorm superficialis to run between its first. The branch actually run along the lateral aspect of the median nerve, and then as it goes distal, it just go away from the nerve and separates from the nerve towards the flexor carpi radialis, and both at this level they are both covered by the antebrachial fascia, but distally, mostly at the level of the distolistic rays, the palmar cutaneous branch actually penetrate the deep brachial fascia to run in the subcutaneous tissue just medial to the flexor carpi radialis tendon. So this is a diagram showing the relation between the palmar cutaneous branch and the median nerve. So this is the median nerve, the main trunk of the median nerve. This is the antebrachial carpi radialis tendon, and medially here and on top of the nerve outside the carpal tunnel is the palmaris longus, emerging from the lateral aspect of the median nerve. It lies very adjacent to it. Really, it will appear as a tiny fascicle separating from the median nerve from the lateral aspect, and then as it goes distal, it becomes away or was distant to the median nerve. It penetrates the antebrachial fascia here at the level of the distolistic rays, and then is directed toward the flexor carpi radialis to lie on its medial side. This is a cadaveric study, a cadaveric figure or image showing the main trunk of the median nerve and showing the palmar cutaneous branch separating or leaving the median nerve from the lateral aspect here on its way to the distal wrist. This is actually very nice. So here at the site of the exit, here the main trunk of the median nerve, this is the palmar cutaneous branch, and this is the antebrachial fascia, and of course the flexor carpi radialis tendon located lateral to the median nerve outside the carpal tunnel. Then as we go distal, you will see that the palmar cutaneous branch gets away from the nerve, is still covered by the antebrachial fascia on its way to penetrate the fascia here. Then this is the penetration point here. It will penetrate the antebrachial fascia to lie in the medial side, to lie superficial in the subcutaneous tissue, so it does not pass through the carpal tunnel, it just lies between medial. So the anatomical variations, actually the anatomical variations of the palmar cutaneous branch is not that common, but what you have to know, just instead of penetrating the antebrachial fascia and travel within the sheath. But actually we don't see the, I didn't see ulnaris longus, so it may pass near the palmaris longus, not on the medial side of the flexor carpi radial, and it may arise from, not from the lateral aspect, but from the common. But it's really important to note that, especially if you are going to cross to like, you want to inject the median nerve, you have to know the direction or the nerve, whether it's medial side or lateral side, just to avoid its injury. So what about this to the mid-forearm to be able to catch the emergence point of the branch from the median nerve? This is a little bit distal, and we can see the main trunk of the median nerve. This is the level of the pronator quadratus at the level at the distal third of the forearm. This is the flexor pectoralis superficialis muscle and tendon starting to form. This is the tendon of the flexor carpi radialis. And you can see, you will see, can you see this one single fascicle leaving the median nerve from the lateral aspect? This is the palmar cutaneous branch. It is a really tiny nerve with a cross-sectional area less than 1 millimeter square. But if you just focus and trace that in the demo videos in the next session. So as we go distal, we will see the nerve, the palmar cutaneous branch, separating from the main trunk, the antebrachial fascia. It does not penetrate here the antebrachial on the medial aspect of the flexor carpi radialis tendon in the subcutaneous tissue. So here, going more distal, can you see this nerve, tiny, small, one fascicle here? It's away separated from the median nerve and it's way here to the subcutaneous tissue. And the next level, here it is after penetration, running superficial to the antebrachial fascia on the medial side of the flexor carpi radialis. Here there is a kind of anisotropy like, because sometimes you have, or the orientation to this branch. So you have, sometimes you create anisotropy in other structures to obtain or the nerve that you are scanning. It is just a vein just running in the subcutaneous tissue. And I know that during live tracing as well. So you will see the scanning technique and tracing in the demo session. So what about the causes of palmar cutaneous branch injury? So the main cause and the most important cause is iatrogenic during carpal tunnel surgery. It may be directly injured, or it may become encased by scar tissue, or if it's partially injured, you may see a neuroma as well in this branch, because it's really superficial and it's really, of course, is not paying attention. The rest, like knife injury or using rotating machine, this is the most common type of traumatic nerve injuries. So when to do neuromuscular ultrasound scanning for this branch? Of course, in cases of post-carpal tunnel surgery, especially if the patient starts to complain of sensory symptoms along the distribution of this branch and the palm, so you may suspect there is compression of the nerve by scar, development of neuroma, or just a cut of the branch. Of course, if the patient has a trauma at this area and you suspect the injury, or you can do like a pre-wrist surgery map to know whether it is located lateral or medial to injection of carpal tunnel. Get short axis injection for the carpal tunnel and try to locate it to prevent its accidental injury if you are using two. If the patient starts to complain of unresolved numbness over this branch for integrity, or that we have just said scar formation or neuroma or something like that. This is just a nice image for an example of a pathology of the palmar cutaneous branch. You can see the main trunk of the median nerve here, and you can see the flexor carpi radialis tendon, and you can see here an enlargement of the palmar cutaneous branch as the case report swollen and changing the echotexture. Of course, sometimes we see ultrasound tunnel sign as well. If you press by your probe, it may provoke symptoms, tingling, numbness, and things like that. This is what we call positive ultrasound tunnel sign. View. It's really hard to capture the longitudinal view. Of course, you can with meticulous scanning and back and forth rotation of the probe, but usually the most important is the axial view. Unless it's traumatic nerve injury, you have to try to obtain the longitudinal view to assess for nerve continuity. Sometimes it's really challenging. So this is a case post-carpal tunnel release. This is lateral, this is medial, this is the main trunk of the medial nerve, and this is the flexor carpi radialis tendon. So what can you see here? Is there any pathology here? You can see the palmar cutaneous branch similar to what we have seen just in the normal scanning. There is no scar tissue around the nerve. There is apparently no swelling or no change in the echo texture. So it's really normal. So negative finding is a finding. So this was the patient referred post-carpal tunnel release because the referring physician suspected injury of the palmar cutaneous branch. But an ultrasound tracing of this nerve down to the subcutaneous tissue level is really normal. So you can assure the patient and the referring physician that there is no injury or affection of the palmar cutaneous branch. So negative finding is actually a finding. So this is in comparison to another case. Already suspected injury of the palmar cutaneous branch because the patient did not improve and had symptoms at the palmar aspect. So it can be antibrachial fascia. This is the main trunk of the medial nerve. This is the flexor carpi. Normal cross-sectional area, normal appearance, nothing here. This branch, this is the medial nerve, flexor carpi radialis tissue. This is just scar tissue, and you can see scar tissue surrounding the palmar cutaneous branch. This is quite different from the previous trap and co-compression of the palmar cutaneous branch. So it's really beneficial in cases of post-carpal tunnel release. Okay. Sorry for this because they had to tell me something about the resolution of the image that you have. Just give me a few seconds. So next we shall move to the dorsal ulnar cutaneous nerve. So the dorsal ulnar cutaneous nerve arises till third of the forearm at about 5 to 8 centimeter approximate to the ulnar styloid. Sometimes a little bit distal, sometimes a little bit proximal, depending on just anatomical variations. And then the nerve will leave the ulnar, the branch will leave the ulnar nerve to run under the flexor carpi ulnaris muscle and tendon. And it will go to toward the extensor compartment, the fifth external compartment, to run the subcutaneous tissues, such just superficial to the extensor carpi ulnaris tendon. I think medical conference keep telling me that the image is not good on your side. So is that true? Can anyone tell me in the question and answer box so I can just... It's clear on my side, so let me just... Is this better? Okay. Sharing and we'll share again to be shared and then... So it's better? Okay. I think it's better now, right? Okay. So the dorsal ulnar cutaneous branch arises here from the ulnar nerve, from the ulnar aspect of the ulnar nerve at a distance about 4 to 5 centimeters, maybe more proximal or distal, as we have just said. It then continues its way distal, and it actually comes from the palmar, from the ulnar palmar aspect, and then it will go directed dorsally to run superficial to supply the sensory area, dorsal area of the hand and the little and ring finger. So when you scan, you have to slide your probe dorsally and direct your probe dorsally to be able to follow it. And it runs superficial here. It runs here superficial in the subcutaneous tissue, just on top of the extensor carpi ulnaris tendon. So this is a cadaveric image showing the ulnar nerve here and showing the dorsal ulnar cutaneous branch separating from the ulnar side of the ulnar nerve on its way to the dorsal a fifth dorsal extensor compartment just superficial to the extensor carpi ulnaris tendon. So the causes of injury as well, you can see it iatrogenic as in open reduction or internal fixation, for example, of ulnar fracture. It may common to see painful neuroma of this branch because it's really superficial here. Traumatic nerve injury as well, and you don't forget that you may find it entrapped in cases of extensor in carpi ulnaris tendinopathy at the fifth compartment. So just you have to screen this area for entrapment or swelling. You can see swelling or increase in nerve cross-sectional area in cases of extensor carpi ulnaris tendinopathy. So the neuromuscular ultrasound indications to scan the dorsal ulnar cutaneous. As well, you can see it in suspected impingement, as we have just said, in cases of extensor carpi ulnaris tendinopathy. Sorry, this is extensor, not flexor. Traumatic nerve injury as well is a good indication. You can use it to guide a block, or you can use it preoperative nerve mapping to avoid iatrogenic injury. And you can need it as well pre-nerve conduction mapping. So we can do nerve mapping before doing the nerve conduction for optimum placement of the electrodes to obtain the optimum response. So in a patient, always remember that in a patient with non-traumatic neuropathy of the dorsal ulnar cutaneous or dorsal ulnar branch, it's usually better to routinely scan the extensor, sorry, again, this is a mistake, extensor carpi ulnaris tendon, searching for tenosynovitis or tendinopathy, and vice versa in cases of extensor carpi ulnaris tendinopathy. Put in mind that you may find entrapment of this branch on top of the tendon. So this is a pseudo-anatomy of the dorsal ulnar cutaneous branch. This is the main trunk of the ulnar nerve. This is the level of the distal forearm, and you can see here the ulnar artery adjacent to the ulnar nerve. You can see on top the flexor carpi ulnaris muscle and its tendon. This is the ulna, and you can see this branch leaving the ulnar aspect of the ulnar nerve. This is the dorsal ulnar. It appears like a train of fascicles, or sometimes a flat or oblong fascicle, leaving the ulnar aspect of the ulnar nerve. So this is the exit point of the dorsal ulnar cutaneous branch. As you go distal, you will see that it separates from the ulnar nerve. Here is a train of fascicle, one here, here, and there, just running under the flexor carpi ulnaris muscle and tendon, between the muscle and the ulna on its way to the subcutaneous tissue. As you go further, it's really tiny and sometimes really challenging because of the ecotexture of the subcutaneous tissue around the nerve. So you have to do back and forth scanning several times to be able to identify this. And this is on its way to run superficial to the extensor carpi ulnaris tendon. This is just here in the subcutaneous tissue. And as you follow it distal as far as you can see it running on top of the extensor carpi ulnaris tendon, the subcutaneous tissue. Here, it can be entrapped in cases of tendinopathy of the extensor carpi ulnaris. So you will see the scanning technique in the demo video session as well. This is just an example of a pathology in the dorsal ulnar cutaneous. This is a patient was referred for traumatic nerve injury of the ulnar nerve at the distal forearm, and we'll see here in the video. This is the ulnar nerve, just proximal, really proximal, just below the level of the cubital tunnel. And you will see that in the video session, the recorded video session on YouTube. As you go distal and follow the nerve, you will see here, this is just at the level of the cubital tunnel. You have to start proximal to the site of the trauma to be able to capture the injury. I think there is some lag here in this video, so let me just get back. Follow, I'm going distal, and you will see here, just here coming, a swelling emerging from the side of the nerve. Here it is abrupt, increase hypoacuticity. This is in case of neuroma of the dorsal ulnar cutaneous nerve, and then the nerve returns back to normal. You will see that in a more nice video in the demo video session. So this is what we have, a static image of what we have just seen. So this is the main trunk of the ulnar nerve, and you can see this is not a swelling of the ulnar nerve, swelling of the branch that's arising from the ulnar aspect of the ulnar nerve. So this is a case in enlarged nerve, hypoechoic branch. This is in the case of neuroma of the dorsal ulnar cutaneous nerve. And if you press by your probe, it will provoke symptoms along the distribution of the dorsal ulnar cutaneous nerve. So next we come to the terminal branches of the ulnar nerve. As you remember from the basic course, we have talked about the zones of the Guyane canal. Zone 1, which is the main zone of the Guyane canal at the level of the pisiform bone, which is occupied with the main trunk of the ulnar nerve. And then as you go distal at the level of the pisiform, you will see, it's divided into two zones. Zone 2 occupied by the motor branch of the ulnar nerve, and Zone 3 is occupied by the sensory branch of the ulnar nerve. So these are the zones that we are going to scan, and we have to start at this level, at the level of the pisiform bone, to see the main trunk and then follow these branches. So after leaving the ulnar nerve, the main ulnar nerve, the deep ulnar motor branch will cross along the medial wall of the hook of the hamate, and it really runs deep, runs deep and follow the course of the deep palmar arch beneath the hyposthenar muscle and the flexor tendons on its way to supply the adductor pulses at the thenar eminence. So you have, if you would want to trace it, it's sometimes really difficult to trace it down to the thenar muscle, but you can trace it as far as here, and just you have to curve your probe to be able to catch the axial view of this nerve. As for the sensory branch, after leaving is occupied, it is just placed in the zone 3 of the Guyane canal. And as after it leaves the main trunk of the ulnar nerve, it divides into two branches and continue as a digital nerves to give sensory innervation to the ring finger and the little finger. So here, the sonoanatomy, you start at the level of the Guyane canal, at the level of the pisiform bone. Just put your probe on in the axial view at the level of the medial distal wrist crease. You can see here the pisiform bone, the ulnar artery, and the main trunk of the ulnar nerve. As you go distal, you will see that it splits into two hypoechoic structures here, this one and this one. And this with the just outing and the tracing of the nerve. This is the borders of the nerve, so this is superficial, and this is the deep branch. If you follow this, this will go deep, and this will continue superficial. Here, they lie adjacent to each other. Sometimes you see at the splitting points, sometimes you see them over each other, sometimes you just see them beside each other, and then this will go deep, and this will continue superficial. As you go distal, you will see its separation. You will see here the superficial, this is zoomed picture showing the superficial ulnar, and actually it starts to split into two branches. One will go to the little finger, the other will go to the side of the other little finger and the ring finger. And this is a deep branch going deep here, and it will run under the hyposthenar muscle. As we go distal, here is the deep ulnar, this is superficial ulnar. It's really normal to see the deep ulnar branch here as an hypoechoic structure. You will not see the claviform or the honeycomb, but actually it's superficial. Sensory, you can see fascicles here actually. So this is a splitting of the superficial ulnar into two branches, one large one and one smaller one. This will go to the little finger, and this will go toward the ring finger. And this is the deep branch of the ulnar nerve. As you go further distal, this is again the ulnar artery, and ulnar artery actually splits into superficial and deep branch as well. This is superficial ulnar sensory, and this is the deep branch going here on its way to the thenar eminence. As you follow the superficial ulnar sensory, you will see that at the level of the metacarpal, just adjacent to the flexor tendons and just adjacent to the digital artery. This is a digital artery. This is superficial ulnar sensory turning into a digital artery here, typical honeycomb structure adjacent to the artery, and both are adjacent to the flexor tendons, and this is the lumbrical muscle. This is just an enlarged image or zoomed image showing this honeycomb structure, the digital branch, and this is a digital artery, and this is the flexor tendons. So it's common to see injury to the branches of the ulnar nerve in long distance cyclists and those who use vibratory tools. And sometimes if there is a ganglion here at this level, it may compress the main trunk of the ulnar nerve or one or two of its branches. This is an example of superficial sensory pathology. This is the case of traumatic ulnar nerve injury. You can see here the deep branch looking normal, and here there is a abrupt change in the size and architecture of the nerve. This was a case of neuroma of the superficial ulnar in a case of traumatic ulnar nerve injury, and you can see the difference between the deep branch. This is not the best quality image because it was captured by, a machine that is not that good. So next, let's move to the musculocutaneous nerve. And as you know, the musculocutaneous nerve is derived or originates from the lateral cord of the brachial plexus with the root values 6, 5, and C7 roots, C5, 6, and 7 roots. And it supplies the coracobrachialis, of course, both heads of the biceps brachii and most of the brachialis. And it continues its pathway till the level of the cubital fossa, where it becomes the lateral cutaneous nerve of the forearm running on the lateral aspect of the cubital fossa. And it first, here is a diagrammatic representation showing the musculocutaneous nerve. This is number 3, the musculocutaneous nerve. This is the white structure in the axillary artery, and then it comes as a brachial artery. This is the median nerve. Can you see the relation between the median nerve and the musculocutaneous? Because the median nerve arises from the lateral cord by a lateral root as well. The median nerve crossing in front of the brachial artery at the level of the mid-arm, and this is the ulnar nerve. So actually, the musculocutaneous nerve is lateral to the median nerve at the level of the axilla, and this is where we will see in the ultrasound. Then the musculocutaneous nerve at the first part of this pathway or its course, it penetrates the coracobrachialis muscle. Then it will pass between the biceps brachii and the coracobrachialis. Then more distal, it will leave the coracobrachialis and just run between the brachialis and the biceps, and it continue its pathway up to, down to the level of the lateral cubital fossa. So this is an image showing the pathway of the musculocutaneous nerve. Here is just passing between the two heads of the coracobrachialis, penetrating the substance of the coracobrachialis. Then it will pass between the biceps, two heads of the biceps brachii and the coracobrachialis, and it will leave this space on its way down to the level of the distal arm, where it will run between the biceps and brachialis. So if we see the sternal anatomy here, do you remember this image from this section, cross-sectional anatomy at the level of the axilla from the basic course? Here are our landmarks, the axillary artery at the center of the image, the axillary vein, and here is the median nerve. This is lateral, there is median. This is the ulnar nerve. This is the radial nerve, and you can see here, if you look just lateral to this structure, lateral to the axillary artery and median nerve, you will see here a structure running between the biceps and coracobrachialis. This is a musculocutaneous nerve. So if you look here, this is the axillary artery. This is the median nerve on the lateral aspect of the axillary artery. And you can see if you just slide your probe or look just lateral to the median nerve on the axillary artery, you will see a honeycomb structure running between two hypoechoic muscles. So this is the musculocutaneous nerve running between the biceps and the coracobrachialis here. Here is sometimes it looks like here like a triangular in shape, sometimes oval or rounded, and sometimes you see it like here, an oblong flat nerve here running between the biceps and coracobrachialis. And this is the proper position for scanning. You have to place the patient in the supine position with the shoulder abducted and externally rotated to open the axilla and see the nerve. Don't forget this chart and this pie chart from the basic course where it described the anatomical variations of the distribution of the peripheral nerves around the axillary artery. And here is the musculocutaneous nerve. So you may find it lying in sector 8 or sector 9 of the pie chart. So you may see it lateral, you may see it superior lateral, or you may see it superior inferior lateral as well. So it may be, you find it at this region. Okay, so as you go further and follow the nerve, it actually splits into fascicle. You will see fascicle in the scanning in the video. You will see fascicle going to the biceps, and you will see here the remaining fascicle running between the biceps and brachial. Sometimes it's really hard to identify here distal because it's really can confuse you with the intermuscular septum. So you have to trace back and forth several times to be sure that you are following the nerve fascicle. Here is the nerve, such tiny nerve here, flat, running between the biceps and brachialis. This corresponding cross-sectional anatomy. Here, the musculocutaneous nerve running between two muscle layers. Of course, it can get entrapped here if there is a biceps muscle hypertrophy, for example. So as for anatomical variations of the musculocutaneous nerve, actually, there are many anatomical variations. First, the musculocutaneous nerve and the median nerve may unite to form a common trunk. So this is the normal course. This is the lateral cord of the brachial plexus, medial cord, and then lateral root and medial root will give rise to the median nerve, and the musculocutaneous nerve just arises from the lateral cord. This is the standard type. Okay, and then the musculocutaneous nerve will supply the coracobrachialis, biceps, and brachialis. You mean sometimes the musculocutaneous nerve and the median nerve unite to form one nerve. In this case, there will be like an exchange of fibers. So actually, the median nerve may give innervation. In this case, for coracobrachialis, biceps, and brachialis. And this is important, especially for nerve conduction study. So if you have a patient, for example, having a median nerve injury, and you did EMG for him, and you find just weird findings in the muscle supplied by the musculocutaneous nerve. So you did EMG, for example, in coracobrachialis, biceps, and brachialis, provided that you can find findings in the EMG, despite that the patient is not having a brachial plexus injury. So if you find this suspect that there is this anatomical variation, there is a union of the musculocutaneous nerve with the median nerve. Sometimes you can see communicating branch between the median nerve and the lateral cutaneous nerve with exchange of the fibers. The level of the communicating branch varies. It may happen just proximal to the innervation point of all muscles. It may happen between the level between the coracobrachialis and biceps brachii innervation. It may happen between the biceps and brachialis, and may happen just distal. Of course, we cannot see the level of this communicating branch exactly in ultrasound, but we can see just the communication or approaching of the musculocutaneous nerve with the approximation to the median nerve at the level of the axilla. So this video showing, I hope it works here. You can see the musculocutaneous nerve. And this is the axillary artery, this is the median nerve, and you can see the musculocutaneous nerve here approaching the median nerve. So it really comes very near. So you expect in such a case, if you see there is exchange, the type of exchange of fibers between the median and musculocutaneous. And here again, separate from it distal. So you can see that and suspect that there is a kind of union or exchange of fibers because it really comes near each other. So what about the injury of the musculocutaneous nerve? So it can be injured, of course, if there is penetrating trauma or closed trauma stretch injury. It can be entrapped with heavy exercise, especially as it passes between the two heads of the coracobrachialis. It may get compressed as a result of muscle hypertrophy or entrapped between the biceps and brachialis for any reason, and stretching injury as well with forced abduction, external rotation of the shoulder. So the indications for neuromuscular ultrasound, suspected traumatic nerve injury, suspected entrapment, and you always can do nerve mapping pre-surgery or pre-soft tissue mass to see the relation between a soft tissue mass and the musculocutaneous nerve. And this is just an example of a case for nerve mapping. This patient was presented with a swelling at the level of the arm and in the suspected soft tissue swelling. You can see here, this is the brachial artery. And as you go proximal, this is the median nerve, and actually the patient has anatomical variations where the median nerve passes behind the brachial artery, not in front of it. And as you go proximal, you will see swelling emerging from the biceps here. Just to give it a second. Here. And you can see that this is swelling actually displays the musculocutaneous nerve right here, pushing it superficial. So you can use ultrasound to see the relation between this mass and the surrounding nerves, median nerve and the musculocutaneous nerve. So here this musculocutaneous nerve. So you will see the normal position of the musculocutaneous nerve, and as you go proximal, you will see there is just this swelling just pushes away the musculocutaneous nerve. You can see, measure the dimensions of the swelling. You can measure the cross-sectional area of the nerves and compare with the other sides. And just it gives an idea about, for the surgeon, if he's going to do any resection or any type of intervention for this swelling, they can know where the nerves lies exactly. So this is helpful for them. So next we come to the last nerve in this lecture, is the medial antebrachial cutaneous nerve. And as you all know, it's derived from the medial cord of the brachial plexus. It travels along the ulnar aspect of the axillary artery and brachial artery, and then along the arm and elbow, it runs just adjacent to the basilic vein, which is used as our landmark to identify the nerve at this level. And actually, as it goes down toward the elbow, it divides into anterior and posterior branch. And here is the relation of the nerve in relation to the basilic vein. So this is the basilic vein. This is the medial antebrachial, dividing just above the elbow into an anterior branch, and then continue just along the side of the basilic vein here. Here is the cross-sectional anatomy. Remember this image as well. This is the axillary artery, the axillary vein. This is lateral, there is medial. This is the median nerve. And we usually look for the medial antebrachial in the area just above the axillary artery and vein, in the space between the median nerve and the ulnar nerve. And you search for a small honeycomb structure running here, and you can follow it distal and backward, back and forth tracing to be sure that this is a nerve. It will come along the side of the basilic vein as you trace the nerve distal. So this is the axillary artery, the axillary vein, the median nerve, and you usually search for the medial antebrachial at this region. So here, just distal to the axilla, you can see a honeycomb structure right here. Just it was here, and then it goes like distal here. This is again the median nerve. This is lateral. This is medial. This is the biceps, and if you look there, you will see the musculocutaneous. This is the axillary vein and the axillary artery, and this is the proposition to scan. The same as we did for the musculocutaneous nerve. So as you go distal, you will see it running just adjacent to the basilic vein. So this is the basilic vein at the level of the mid-arm. And you can see here a triangular honeycomb structure running adjacent to the basilic vein. If you look, you can see here the brachial artery, and here is a median nerve crossing in front of the artery. So this is an again axial image at the level of the axilla. Here is the axillary vein, and you can see three nerves around the veins. So what are these? Can anyone tell me? We expect this one. This is lateral and this is medial. So we expect this is the median nerve, right? And this is, you may see, you may just posterior, you may think that this is the radial. And you may think that we are medial here and this is the ulnar, but actually this was not the case. This is what actually the median nerve, this is what the ulnar nerve, and this is the medial antebrachial. So you can see there is like anatomical variation in the distribution of the nerves. So you will never be sure which nerve is nerve if you just scan at the level of the axilla. So you have to trace the nerve from a distal level, especially the main trunks, or if you start at the axilla, you have to trace these nerves distal to see their course distal. So if medial nerve, it will turn into medial, and you will see it crossing in front of the brachial artery. This patient has anatomical variations in relation to the medial nerve and the ulnar nerve, and it really comes close to each other along the entire length of the arm. And this is just here in beneath the axillary vein, not on its medial side. And this is actually what the medial antebrachial located here, not as we have just seen here. So you can find injury of the musculocutaneous nerve. Here is the medial antebrachial nerve. And here it divides into branch, anterior branch and posterior branch. And you can see here the ulnar nerve here going to the ulnar groove and then to the cubital tunnel. And the branch is really near the ulnar nerve. So it can be injured during injection for medial epicondylitis or cubital tunnel, or can be injured during cubital tunnel release. It can be injured as well in venous punctures. And actually, it may snap over the medial epicondyle. This is an interesting actually finding. So this is the ulnar nerve, the ulnar groove, medial epicondyle here, medial head of the triceps, and you can see this tiny branch on top of the nerve. And this is actually an interesting study showing here snapping and jumping of the medial antebrachial here in elbow extension, and with flexion, it just jumps in front of the medial epicondyle. This is what is called, what is known as snapping of the medial antebrachial nerve. So snapping at the elbow may include subluxation, dislocation of the ulnar nerve. You may see triceps snapping, and added to this, you may see snapping of the medial antebrachial. Of course, sometimes it's really challenging to see here at this level. So indications for neuromuscular. If you suspect there is a neuroma or injury of this nerve post-cubital tunnel release, the patient will have symptoms along the distribution of the nerve along the medial side of the forearm, can be injured as we have just said in venous puncture or injection for medial epicondylitis or cubital tunnel release. You can do scanning of the nerve for these indications. So last, I would like to conclude just by a general assessment protocol for such tiny nerves. So the assessment protocol is that, of course, for any nerve, we have to measure the size. We have to trace the nerve along its entire course or the branch. We have to measure its cross-sectional area, and the cross-sectional area is the most important measurement. And for such tiny nerves, you have to depend on the side-to-side comparison, because we don't have actually reference values for such tiny nerves, but usually it's less than 1 millimeter square. So if you find it like 4 or 5, it's definitely pathological. You can assess the ecotexture. Of course, it's not applicable in all nerves, because sometimes a really tiny nerve and just a dot and one fascicle, but it applies to the, for example, the musculocutaneous nerve, where you can see the fascicular structure. You can assess as well vascularity. Don't forget to look for structural compressive factor like ganglion, bone fragment, or accessory muscle, or any anatomical variations. And if it's the case for traumatic nerve injury, you try to look for continuity, for presence or absence of neuroma, or encasement of scar tissue, as we have seen for the palmar cutaneous branch. And don't forget to assess the innervated muscle. This is the ideal, or the neuromuscular ultrasound protocol is just to scan the innervated muscle if you are examining a motor nerve or a motor branch. This is important. The same way as we do an EMG for after nerve conduction, it's important to see the muscles innervated by these branches and nerves. So you assess the size, we use the tracing method, okay? And here, for example, you see the structural factor. This is an accessory ATM overlying the ulnar nerve at the level of the Guyne canal, so it may compression. You have to do side-to-side comparison, and the accepted side-to-side difference is within the range of 0.3 to 0.6 millimeter. If traumatic and there is a neuroma, you can measure it and in a cross-sectional area or in the diameters. And don't forget to examine the innervated muscle. This is a picture for traumatic ulnar nerve injury, and you can see here a difference in the ecotexture between the hypothenar muscle on this side versus this side. This indicating denervation and chronic axonal change, and the muscle turns extremely hyperechoic. So in conclusion, for this tiny nerve, I know they can be challenging and depressing and disappointing, but with practice, you will be able to see them. Anatomy is the key to tracing. Tracing for these nerves depends on all nerves as well. Tracing is all about visual tracking and eye-hand coordination, so you have to develop them. And tracing back and forth is key to identify these small, tiny nerves, to be able to just capture them as they originate from the main trunk and follow them. The neuromuscular ultrasound indications for such tiny nerves, including iatrogenic injury, as we have just said, traumatic entrapment, and nerve mapping. Nerve mapping, you can do nerve mapping before surgery. You can do nerve mapping before a nerve conduction study to optimize your technique. You can do it mapping before, like in case of soft tissue method we have just seen, and you can do mapping even prior to injection around these nerves. Just set an examination protocol, size, cross-sectional area, echogenicity, vascularity, structural factors, and just stick with the examination protocol. And thank you so much for your attention. So I think we should, as I have mentioned in the beginning of the day, we have to stop for the Friday prayer, okay? Because here in Egypt and Arab countries, we have to stop at 12 or at the time of the Friday prayer for those participants who want to go to the mosque. So we have to stop, but I will leave you with the link. Just give me, I will answer the questions and answer after we come back from the break, okay? But just let me, I will leave those who will not, who don't live in Egypt or the Arab countries, I will leave them with the link of the videos to watch the tracing of these branches that we have just discussed. So let me share just the presentation. So to see the video demo, we will have to redirect you to a YouTube link because the videos are actually long, and if I share them here, they will be very slow and there will be a lag between my voice and the video. So it's better for you to watch them through YouTube link. Okay, I will copy and paste this link in the chat box. The videos are for 5 videos, video for each branch collected in one playlist, and they will take about 43 minutes to watch. So we have to break. So I will give you a break, and those who will not go to the prayer, they can watch the videos. And if you are going to the prayer, you can get back after the prayer and watch the videos as well. So I will leave like a half an hour for the prayer and 43 minutes for the videos to watch. So we will get back at 1:10 p.m. for questions on this lecture and to go on with the last session. But just before you watch the videos, I would like just to show you, to show you the tracing path of each branch. So to scan the palmar cutaneous branch of the medial nerve, you start at the mid-forearm, and from there you keep going along the midline of the forearm down to the level of the distal wrist crease. So this is your tracing path for the palmar cutaneous branch. This is for the dorsal ulnar. You start at the level of the mid-forearm as well, along the medial side of the forearm. Continue along the medial aspect of the forearm, but as you go distal, you will have to curve and turn your probe right here because the nerve goes distal toward the 5th extensor compartment, okay? And this is a scanning for the terminal branch. You start at the level of the Guyane canal, and as you go distal. For the deep branch, you have to incline the probe because it goes this way toward the thinner eminence, and then continue with the superficial branch down to the level of the digits. For scanning of the musculocutaneous nerve, you have to start at the level of axilla and follow it from the medial aspect, and you have to go a little bit distal at the level of the mid-forearm. You will go in the midline because it just runs between the biceps and brachialis, and down here to the lateral cubital fossa. For the medial antebrachial, we start at the same at the level of the axilla, but we follow the nerve medial. along the medial side of the forearm down to the cubital fossa if we can to do that. Okay, just a tip to improve the visibility of the nerve branch, small nerve, they are really challenging, and you will see that in the videos, I'm going to show you a back and forth tracing of the nerve several times. So to improve visibility, the main key is back and forth tracing. You may have to incline your probe to achieve orthogonal orientation to the nerve. Sometimes dynamic movement of the surrounding muscle help in the recognition of these nerves. And you have to just relatively trace the nerve, not too fast, but not too slow. Sometimes too slow tracing will prevent you from following and visually track these branches. So in a minute, I will just put this link for you, and we will come back at 1:10 for the questions and to continue our last session. Thank you. So hi everyone, welcome back. I hope you have finished the videos. If you didn't yet, you just can see them later on. Just notice in the videos that sometimes in some parts of the videos, the focal point is not that optimally adjusted. This is just because I have made these recordings on myself. So I have to just hold the probe on one side, on one hand, and scanning the other side. So I'm aware of that, so don't worry, this was just for preparation of the videos, but I just wanted to show you the branches and back and forth tracing several times. So I hope the videos are good enough. So I can see questions and in the question and answer box, but I think we shall postpone them to the end. So we can discuss the two lectures together, the last lecture and the next lecture that I'm going to give, which is about dynamic muscle ultrasound. So I think we should postpone these questions. I will answer them all at the end. Just to complete the program, to finish the program, and just we'll have time as you wish for discussion and answering all these questions. So let me share the screen. I know that it has been a long day, and actually the program today was rich and heavy. I know that. So I hope that you have some energy to listen to this last talk, and I hope you find it interesting. Because I really find this is really an interesting topic for me. Because dynamic muscle ultrasound just show us how amazing ultrasound is. And we all know that one of the main advantages of ultrasound is dynamic ability and its ability to see things in real time. Before I start, I just want to confirm that I don't have any conflicts of interest to declare. And then what is dynamic muscle ultrasound? Dynamic muscle ultrasound simply capture of movements in real time via ultrasound. And we can predict that the info that we can get from a dynamic image is quite different from the info that we can get from a static image. So for example, if you see a person moving, what info can you get different from the info seeing him sitting? Of course, we can see the movement. We can determine if his movement is normal or not. We can determine the direction of his movement and the amplitude of this movement, and we can actually calculate the velocity if we know the distance that he has walked and the time that has been taken to for the walk. So this is exactly what we see in dynamic muscle ultrasound. We can see the movement of the muscle, and we can see if they are normal physiological movement or it's abnormal pathological. This is actually achieved through the B mode of the ultrasound. And we can see the direction of movement, whether it's direction toward the probe or away from the probe. And we can see the amplitude of the excursion or the magnitude of this movement. And we can see the velocity. We can calculate the velocity as well. And this is actually achieved through the M mode. And it mostly applied to the diaphragm ultrasound rather than the skeletal muscle, as we shall see in the lecture. So the main domains of dynamic muscle ultrasound that I'm going to focus on today are skeletal muscle movement, the utility of the dynamic muscle ultrasound to assess the skeletal muscle movement, the diaphragm, the ability of the ultrasound to assess the diaphragm structure and function. This is an important application. And I will give hint at the end of the talk about the ability of ultrasound to study the muscle architecture, dynamic change in response to contraction or in response to sports. And this is actually a domain that can be interesting for those who work in the field of sports medicine. These two applications, the skeletal muscle movement and diaphragm, you actually can use them in the daily clinical practice. So I will start first just a review of the physics that is behind our ability to see the dynamic movement or to see the movements in real time. We will then talk about the skeletal muscle movement that we can record using ultrasound. We'll just give a focus on ALS because it's really important in ALS. We'll then talk about the diaphragm ultrasound, then we'll end by muscle architecture dynamic change, and we'll just give a very short hint about other applications. We'll see that the applications of dynamic muscle ultrasound are actually endless, and there are emerging domains every now and then. So let's start with the physics. So the ability of ultrasound to see the movements in real time, or the capture of muscle movement or any movement, depends on the temporal resolution. And as we know in ultrasound, we have axial resolution, lateral resolution, contrast resolution, and temporal resolution. This is what we will focus on. Axial resolution, as you know, is the ability of the ultrasound system to differentiate two structures as two separate structures lying tandem to each other or behind each other along a plane which is perpendicular to which is parallel to the ultrasound beam. While lateral resolution is the ability of the ultrasound system to differentiate between two structures lying adjacent to each other along a plane perpendicular to the ultrasound beam. So our ability to see, for example, the ulnar nerve beside ulnar artery, and the ability to differentiate between those structures and see them as two separate structures depend on the lateral resolution. Contrast resolution is the ability of the ultrasound system to differentiate different shades of gray. So we can differentiate if this structure is hyperechoic, hypoechoic, isoechoic, or whatever. And the temporal resolution is defined simply as the ability of the ultrasound system to see the movement of structure. So our ability to see that this structure has moved from this point to this point over a certain period of time. So the main determinant of temporal resolution is the frame rate. The frame rate is defined as the number of the frames acquired per second. And there is a linear relationship between the temporal resolution and the frame rate. Increasing the frame rate will improve the temporal resolution. So what is frame rate? Actually, the anatomical structure that we see on the ultrasound screen or displayed are actually just sequential frames captured over time. And each frame is created from repeated pulses that form the scan line. So these are what we call scan line. This is the field of image in a linear probe. So we get a rectangular image. This is just representation of one frame, and the one frame consists of many scan lines. So this is one scan line, this is another scan line, and they are produced and created in sequence. We'll get clear more with the next. This is the scan line. So for example, this is the ultrasound probe. For example, imagine this is ultrasound probe emitting the ultrasound pulse. It will emit ultrasound pulse in the form of one scan line. And the ultrasound probe has to wait for the echoes to hit the target structure down to the full depth of the structure and get back reflected to the ultrasound beam to be able to start this next scan line. And then the next scan line will be added to the first, and then here 5 or more scan lines added to these lines. And we continue this process till we are done with the all scan lines. And when the all scan lines are complete, then one frame rate is acquired. Here is consisting of about 100 scan lines. And the scan line actually is produced through a series of echoes. So here, the ultrasound beam or the ultrasound pulse emit an echo along the scan line. It will be interpreted as a dot, and then another echo will be interpreted as another dot, and this process will continue in series till we have one scan line. So this is a graphic representation of how the scan line is created or formed. And this is how the frame line is formed. One frame is formed. So imagine as well, this is the basic actually in echocardiography to see the valves of the heart. So as well, this is the ultrasound probe. This is just a sector curved image. And imagine this is our scan lines produced in sequence. And when these scan lines are complete, frame rate will be one frame is acquired. And this process is repeated till we acquire multiple frames and will be interpreted as an image here. And if the frame rate is high enough, we'll be able to see the movement of the structure, like here, the valves of the heart. And our eyes can see image as real time, or can see specifically the muscle as movement of the muscle when the frame rate is more than 15 frames per second. This is important, that there are factors that depend that affect the temporal resolution. And the temporal resolution depends on the time required to complete one frame of okay. So if we need more time to complete one frame, this means that the number of the frames acquired per second will be low, which means low temporal resolution. So what are the factors that affect the temporal resolution or the frame rate? The ultrasound speed, the depth of the image, the number of scan lines, the number of focal points. It is important. Sector or field width. Number of focal points is really important, because we usually recommend, when we want to see abnormal muscle movement, just not to use more than one focal point, one or two maximum, to avoid to be able to pick the abnormal muscle movement. So imagine this is a diagram or an image that show the same that you have just seen, multiple scan lines, and has to complete one scan line, and the echo should reach to this level to be able to start the other scan line, and so on, as we have just seen. And we can notice that the distance or the depth affect the time required to acquire one frame. So if we decrease the depth or decrease the distance, that means that the echoes will travel for a short distance, or the scan line will travel for a shorter distance, and in turn it will increase the frame rate. Same effect if we use the smaller image sector. The time taken to complete this scan line will be low. The time taken to acquire one frame will be low, and it will increase the frame rate. Imagine they are using multiple focal points. So we have to focus the ultrasound beam, and the pulse should be repeated at this level and this level according to the number of focal points. So this will in turn increase the time required to acquire one frame, and in turn will degrade the temporal resolution. So if you want to achieve good temporal resolution, you have to close or turn off your multifocal knob. Same applies if you use fewer scan line, you may increase the frame rate. So just remember the inverse relationship between the frame rate and each of the depth, sector, width, line density, and number of focal points, and you can read more about this if you want. And you can try on your machine. This is the frame rate here, mentioning 21 Hertz. And you can just manipulate and play with your focal points and just adjust your depth and try different depths and see how it changes the frame rate. Just grab your image and try it yourself. So the next question that may arise, which ultrasound mode should we use for dynamic muscle ultrasound? Is it a B mode or M mode? Well, we can use both, and each mode gives us a different info. So here the B mode is the brightness mode or two-dimensional mode, which gives us an ultrasound image that we can see from side to side, the structure from side to side, from superficial to deep, and it's produced by multiple scan lines, as we have just seen, targeting and hitting all the borders and the points of the structure to be interpreted as a blood vessel or nerve or whatever. So in this mode, we can see the muscle movement. We can see if it's physiological, like muscle contraction, or abnormal, like fasciculation and fibrillation. And we can determine the pattern. And the pattern of the abnormal movement will determine the diagnosis, whether it is fasciculation or identification of muscle movement, accurately saying. So we'll see that in just a few slides. M mode, in contrast, is the mode of ultrasound in which one single line is emitted, received, and displayed graphically. So this is we use this as one scan line, use B mode, and then we choose the scan line to focus the ultrasound beam on. It's usually chosen to be fixed along the center for muscle. We're talking about the center of the muscle. And for diaphragm, for example, we're talking about adjusting this scan line along the center of the diaphragm, where the area is expected to show the maximum excursion. And it is represented here, the movement is represented like a wave, like here, with the y-axis representing the amplitude of the movement, and the wave and the upward and downward deflection of the wave represent the direction of movement of the target structure or the muscle or the diaphragm toward or away from the probe. So for example, if the diaphragm moves downward during inspiration, we will see that later on. That means that it will move toward the probe and will cause an upward wave, while during expiration, it will move away from the probe, leading to a negative deflection. So we can know the direction of movement, we can know the amplitude by measuring the y-axis, and it's plotted against the x-axis, which is the time axis. And by knowing the time that has been taken for the contraction to occur, we can, and knowing the amplitude here, which is corresponding to a distance, we can actually calculate the velocity. So this M mode is characterized by really high temporal resolution because of high sampling frequency, and it's really efficient in cases for diaphragm ultrasound. So what are the muscle movements that we can record by ultrasound? Where the muscle movements can be divided or categorized into voluntary muscle movement and involuntary. And involuntary muscle can be fasciculation and fibrillation. We're going to focus on these two muscle movements because mainly the evidence-based data is available on these topics. But actually we can see the myokemia, the cramp, the tremors, but actually don't have strong data about the utility of ultrasound in these. So we'll just mention them rapidly, but we'll focus on the fasciculations and fibrillation, and mainly fasciculations because we can use it in daily practice and it's really beneficial for detection of fasciculation. So normally when you scan the muscle at rest where the patient is fully relaxed, what can you see? You should not see anything. You should not see any displacement of the muscle fascicle. You should see the muscle, if we can say, at rest silent, same as we see it in EMG. Or you can see or completely the patient relaxed, but you can see what you can see at rest as well. Just pulsating movement. If there's a nearby artery near the muscle, you can see the muscle movement in a rhythmic regular pattern. And if you put WC blood vessel here, so this is just arterial pulsations reflecting as irregular rhythmic, just minimal displacement of the muscle, and you'll find it fixed at one place, not in all the muscle areas. And you can put Doppler to be sure. And this is actually one of the say may be source of confusion when you see the fasciculations or fibrillation, as we shall say after a while. So what about the voluntary muscle contraction? On muscle contraction, the muscle size increase and the echogenicity decrease. So for example, here, if I'm contracting the flexor digitorum profundus here, the level of the mid-forearm, you can see that the cross-sectional area increase and the muscle fascicles become hypoechoic with contraction. And the overall shape of the muscle contracting is altered. This is, we'll use it as a differentiating factor with other muscle movement. So the pitfalls when you are scanning the muscle to search for pathological abnormal movement, the pitfalls that you should be aware of are voluntary muscle contraction, arterial pulsation, even probe movement may cause some muscle movement that may confuse you with abnormal pathological movement, especially like fibrillation. So to assess involuntary movement and to avoid these pitfalls, you have to be sure that the patient is fully relaxed. You have to keep your probe steady at all times. Sometimes you use a fixator or something to fix the position of the probe. And it's really important to take care of the temperature of the room and the distal muscle as well, especially if you are searching for fibrillation, because the fibrillation are highly sensitive to temperature change. So the temperature should be at least 34 degrees. Don't forget that the frame rate should be high enough, at least 15 frames per second, or maybe even higher when you are searching for defined oscillatory movement like the fibrillation. So let's start with the fasciculation. What is the sonographic picture or the appearance of fasciculation? It's really clear, and once you see it, you'll be able to identify it very easy. So the muscle fasciculation in ultrasound appears as involuntary, random, focal, jerky movement affecting different parts of the muscle. So try to focus on the image when I play the video, and you will see there is a displacement of the muscle fascicle as if the muscle fascicle are jumping, affecting different muscle area, jerky and involuntary, and random and irregular. So you can see here, jumping of one fascicle right here, and another one. I'll play it again. Here is another one. This is, of course, not voluntary contraction because there is no overall shape, there's no change in the overall shape of the muscle, just a change of the muscle fascicle, displacement of the muscle fascicle. And you are sure, of course, when you judge this fasciculation or not, you are sure that the patient is fully relaxed and you are avoiding the pitfall. This is, of course, not similar to the arterial pulsation, which is fixed in one place and regular and rhythmic. So here it is. We'll see it in another video. The advantage actually of ultrasound detect fasciculation is really nice to see fasciculation because you can scan large areas in a short time and you can access the deep muscle that you cannot examine by visual inspection to see and check if there is fasciculation by clinical examination or not. And it's really beneficial for the painful areas where you cannot insert the EMG. And is actually quick and painless scan of large areas. So here again, we'll see the muscle fasciculation. Just focus here, jumping of one fascicle here, another one here, here another one. This is a typical picture of fasciculation. Sometimes it is really extensive and involving all areas, and sometimes just few here, another one here. And you have, as we shall see, and we'll have to wait for about at least 20 seconds to be able to capture this. So just don't put the probe for 5 seconds and just judge the no fasciculation or not. You have to wait at least 20 seconds. Sometimes they recommend to wait for 30 seconds to be able to pick this. And you can actually count the number of fasciculations in a 10-second period, because actually I will see the reason behind that in the next slides. So for the assessment of fasciculation, you can assess the fasciculation online, like during the examination of the patient, and you can assess it as well offline. So you can record the video for at least 30 seconds, and then you examine the video post-examination offline, and you can count them and judge. And this is not a problem for fasciculation, but you will see that it's a problem for fibrillation. So fasciculation, presence of fasciculation in the proximal muscle is highly indicative of pathological fasciculation, especially in ALS. We can see it as well in deep muscle, as we have just said. We can see it in paraspinal muscle. It's really helpful to see that. This is another video showing the fasciculation. And see one jump here. Here another one. Here another one. Sudden, involuntary, jerky, irregular, affecting multiple areas of the muscle. So not just that, we can see the fasciculation in limb muscle, and we can see it actually in the tongue. So this is a case of ALS. Okay, and this is the digastric muscle. We just place the probe under the chin. This is the geniohyoid, and we will focus on this area of genioglossus muscle, and just focus with me when the video plays. You will see the same abnormal movement. Just focus on this area. It will come. Just give it some time. You will notice jump of the fascicles. Here, this is jump of muscle fascicle here. Video is slightly slow, but just give it some time. And here another one. Can you see that? The displacement, sudden, jerky, abnormal movement is really helpful, because the patients may not accept inserting a needle in his tongue or her tongue. Can you see this is another one? Fasciculation right here. So it's really helpful. So the questions that I expect to be asked, like, can we differentiate between physiological and pathological fasciculation using ultrasound? Well, there are usually in any diagnostic tool, there are possibility for false positive and false negative, but we have some criteria that we can judge if it's physiological or pathological. First, the distribution of the fasciculation. The physiological mainly affect the distal muscle, like the distal leg muscle or the foot muscle. So you can try it on yourself. You may put your probe and place your probe on the extensor digitorum brevis, and you can see fasciculation, normal physiological fasciculations in the distal foot muscle. While if pathological, it mainly affect the proximal muscle, and it mainly affects more than one muscle. So you will see it in the biceps, triceps, and quads. You don't see that in physiological. and mainly and the account of the fasciculation. Pathological fasciculation are usually more than 4 fasciculations in a 10-second period, while physiological it may involve a single area. Additionally, and most important, are the other associated ultrasound findings. It's pathological, as in cases of ALS. You will find, in addition to presence of fasciculation, you can find nerve atrophy, as Dr. Natalie Winter have mentioned in her lecture. And you will see, as a result of the chronic axonal change, you will see the muscles hyperechoic. But in cases of physiological fasciculation, you will not find any other abnormal ultrasound findings unless the patient has other disease that goes hyperechogenicity of the muscle, for example. So let's focus on ALS, because it's the main indication for muscle ultrasound if you are looking for fasciculation. So what the evidence that we have? This is just a few examples, and you can just search on PubMed or Google Scholar, and you will see several studies addressing this point. So what we know that the fasciculations is actually more sensitive than the EMG, and 33% of all fasciculation ALS are EMG negative. Fasciculations were found in 49% of the ALS patients compared to the mimics like the multifocal or CIDP, with the highly sensitive and specific to differentiate between ALS and its mimics. We know that it's less evident in advanced case, and it's expected due to fibrosis. It's mainly evident in the acute or in the progressing phase of the disease, where the anterior horn cell is still under acute innervation and still irritated. It's more evident in the proximal and distal muscle, as we have just said, and actually it can identify the fasciculation in the cranial innervated muscle in ALS with similar sensitivity as EMG. So the questions that I expect as well. So when to do dynamic muscle ultrasound in ALS? First, of course, if you are confused, in confusing cases, sometimes there are contradiction between the clinical picture and the electrodiagnostic study. And sometimes the referring physician is really confused. So if you want to add to the tool that you use to assess ALS patient to differentiate ALS from its mimics, mainly the multifocal and CIDP, you can use dynamic muscle ultrasound, because in multifocal and CIDP, we don't see nerve atrophy and we don't see fasciculation, while in ALS, actually the only neuromuscular disease that we have seen a nerve atrophy is ALS. Some places it is routine to do for ALS patients to screen for them. Another indication is just if the electrodiagnostic criteria almost fulfilled, but you cannot find fasciculation EMGs. So it increased the possibility of finding fasciculation if you use ultrasound. And the really interesting application for dynamic muscle ultrasound is to use it actually before you do EMG. So you can rapidly screen the muscles, large areas of muscle, proximal and distal muscle, and upper and lower limb to see which muscles show fasciculation by ultrasound, and then focus your MG study on this muscle to increase the yield of finding fasciculation. It's really interesting. And I really like the way ultrasound can help us to optimize our nerve conduction EMG technique. It's really one of the most important, from my point of view, for the neuromuscular ultrasound and its utility in the EMG lab. You can use it as well if you cannot for deep muscle, for the paraspinal, for the painful areas, cranial muscles, or the tongue, as we have just seen. So the protocol of dynamic ultrasound in ALS, if you have an ALS patient and you want to screen for fasciculation, what you shall do? First, position your patient in the supine position. Be sure he or she is fully relaxed. Don't forget the adjustment of the room and body temperature. And you have to scan upper and lower limb muscle with a focus on the proximal muscle. And if you suspect fasciculation in tongue, you can scan the tongue as well. We usually use the axial view to be able to see the fasciculation, and we choose the most bulky level, but you have to scan multiple areas of the muscle, so you can focus the ultrasound probe on the lateral part, then shift to the mid part, then shift to the lateral part of the muscle. You have to choose proximal and distal muscle to be able to detect the pattern, and you have to observe for at least 20 seconds and better 30 seconds. And as we have just said, you can count the fasciculation live or using recorded videos, provided that you have recorded the movement for 30 seconds at least. So this is a nice study which has investigated the frequency of fasciculation using ultrasound in different muscles. And they found that the frequency of fasciculation is higher in biceps, triceps, extensor digitorum, flexor digitorum superficialis, flexor carpi ulnaris, and quad. And it's least frequent in sternocleidomastoid and in the distal muscle like the gastrocnemius. So this is really like the abdominal muscle. It's really helpful for you to choose the muscle dynamic scan, because this is where you can see the fasciculation. So interesting study as well has investigated the muscle ultrasound fasciculation score. So in this study, the authors developed the muscle fasciculation ultrasound score. They have chosen 9 pre-selected muscle: trapezius, deltoid, biceps, abductor pollicis brevis, abdominal muscle, vastus lateralis, medialis, biceps, and gastrocnemius. And then they scan this muscle and count the number of the muscle with fasciculation. And the interesting finding is that they have found that there is a highly significant difference in this in the ALS patient versus non-ALS patient as regard this score, with a high diagnostic sensitivity area under the curve equal 0.97 and the cutoff value more than 2. And you can see that with the advancements and with more research in this area, I think in the future we will have like a diagnostic criteria and more scores and scales. So this is just show you how the advancement of the field is going. Another interesting actually research on this field is trials to develop automated methods for automatic detection of the fasciculation, in contrast to just not to depend on our relatively subjective assessment of the muscle instead of depending on our eyes to see the fasciculation. This is actually a complicated process because it's usually of interest in the bioengineer field and actually published in the bioengineer journals, where they used a complicated algorithm to try to develop automated methods for detection. So this is just for you if anyone is interested. You can check these studies or read more, but actually I see it's really complicated. But it's really helpful and give us hope that this at least will help us as a clinician in the future, may help us as a clinician to achieve objective assessment of fasciculation. So next we'll move with the second muscle movement that we can see, which is the fibrillation. And the question was always during the past years or the past decade, is ultrasound capable of visualizing fibrillation or not? Well, we have to agree on something first, that we cannot see individual muscle fibers via ultrasound. The resolution of ultrasound simply does not allow us to see that. But what we can see is actually the displacement of the surrounding muscle tissue caused by the fibrillation potential. Okay, so what we see the displacement, we don't see the fibrillation. So what I see in ultrasound is not the fibrillation, it is the displacement of the surrounding tissue as a result of the fibrillation potential. But given the facts based on the literature and the evidence base, actually the ultrasound is not as sensitive to, is not as sensitive for detection of fibrillation compared to its sensitivity in fasciculation. I'm aware only of 2 studies that have addressed and investigated the sensitivity of ultrasound in fibrillation, and they have found a low sensitivity. But the idea itself that we can see the effect of fibrillation on the muscle is really interesting and promising. Of course, still the EMG is still the tool that's suited best for assessment of fibrillation. So how the fibrillation look like in ultrasound? This is a nice study by Bell et al. And they have just seen videos for the fibrillation. So this is the EMG sound and recording of the fibrillation, and this is the corresponding ultrasound image captured during the EMG study, and you can see the ventricular fibrillation as a small, irregular oscillatory movement in all directions. You can see that's quite different from fasciculation. Just a fine oscillatory movement without the jumping of the muscle fascicle that we have seen in the fasciculation, and there is no overall change in the shape of the muscle, which differentiates fibrillation from the voluntary contraction, for example, and arterial pulsation. So once again, just fine oscillatory movement. Really interesting to see that. The frame rate should be higher than that's used for a detection of fasciculation. It should be 20 or maybe 50 or 70. Sometimes you may use zoom to increase the frame rate up to 50, but actually it will decrease your field of view. Try not to use an enhancing setting, and I forgot to tell you that you don't, that's for detection of muscle movement, and so as not to affect the frame rate, the resistance should be very low or zero, because resistance remove the noise and average the frame, and it will degrade the temporal resolution. So you have to scan at different parts of the body as well, and you better to evaluate it live during examination. You will not be able to detect if you examine this in a recorded video offline. You'll not be able to be sure that this is just as a result of probe movement or patient movement, because actually this is our fine oscillatory movement. So you have to be sure that these pitfalls are not there. You have to be sure that's not voluntary contraction, that the patient is not moving, the probe is not moving, and it's not a contraction, for example, the tremor. Sometimes if there is fasciculation and fibrillation, if the fasciculation especially is extensive and vigorous, it may mask the fibrillation. This is a bit false for when we scan for detection of fibrillation. So you have to be sure of these factors live during examination of the patient. You'll not be able to be sure of that. These pitfalls are not present if you just examine the recorded videos offline. So we are done with the fasciculation, fibrillation, and this is a nice table showing the description of the different pathological movement and the pitfalls and description, the ultrasound description for each. It is just extracted from Neuromuscular Ultrasound textbook by Dr. Walker and Dr. Cartwright. And this is actually very interesting because from the pattern, usually we use the ultrasound, all about the ultrasound, especially its utility to differentiate between, for example, different muscle disorder or different nerve disorder, as Dr. Natalie and Dr. Doris have just explained to us. It's all about the pattern of the finding. And the same applies for the abnormal muscle movement, depending on the pattern, whether it's short, jerky, irregular, or it's fine oscillatory, whether it is like tremors, vigorous contraction. This will help us to reach a diagnosis or actually to identify which pathological movement we are seeing. So, but we have to admit that we don't know everything about the abnormal muscle movement. We don't have full sonographic criteria for the different movements, including abnormal muscle movement or movement disorder. And just an example of one case, a female patient teenage was complaining of persistent vigorous contraction of the fibular muscle of the leg since the childhood. And really was referred for me from my professor, Dr. Nagla Ali. And she could not find any abnormal findings in the EMG and nerve conduction. And this is her ultrasound video for the muscle, for the fibular muscle. You can see the muscle actually is contracting, vigorous rhythmic contraction all over the muscle. It's not different, it's not fasciculation. It's quite different from the fasciculation that you have seen, and quite different from the fibrillation that we have just seen. It's not myokemia, which appears like a vermiform movement. It's not vigorous. It's not like a tremor. It's not cramps. So we are not sure that what in the diagnosis of these patients actually was confusing. And I have asked actually my mentors, Dr. Walker and Dr. Cartwright, about it when I saw this patient, and they were not sure as well. And shows us that we don't know everything about this domain yet. But I have just shown you that to show that from the different pattern, and as we see more patients, as we do more research in this area, we'll be able to identify this. Actually, they suggested that maybe a kind of dystonia or a kind of fail movement disorder, because it's really constant all over the day, along the day, and it does not stop. I think even, I think it's decreased with sleep. So it may be kind of dystonia or movement disorder. And you can see here in this video, that the tendon as well, if you scan and trace the muscle down to the tendon, this is a vigorous contraction of her tendons, peroneal tendons at the level of the lateral ankle. She was referred to neurology, and I lost her in the follow-up visit, so I'm not sure the results of her investigations. So to summarize the technique to capture involuntary movement, the practical part. So again, patient position is very important. Fully relaxed, better in supine. You have at first to scan the muscle, optimize your static B mode image, adjust the frame rate, depth, see the frame rate, avoid using more than 2 focal points. Don't forget the temperature. Place the probe in axial view. Try to keep it steady at all times. Scan multiple areas of each muscle with a special focus on the proximal muscle or the muscle where you expect to find the fasciculation. Observe for at least 20 seconds, better 30. And you observe abnormal and you suspect it's abnormal movement, you have to check for the beat force first. Check this is not voluntary contraction. This is not arterial pulsation. Assess fasciculation online or offline, but assess the fibrillation only online, as we have just mentioned. So let's next move to the diaphragm ultrasound. It's a really interesting topic. It needs actually a separate lecture, but I will just give a hint about it and how it can help the patients. So for diaphragm ultrasound, we can use the B mode and the M mode as well. In the B mode, we can see the thickness of the diaphragm and the change of thickness of the diaphragm in inspiration compared to the quiet breathing. And we can know the distance or the depth of the diaphragm, where the diaphragm lies from the skin. So this can help us to determine the size of the needle and how far we can go, how far we need to go to examine the diaphragm using needle EMG. And it can help us to detect the best intercostal space where we should insert the needle EMG. In B mode, as we have just mentioned in the beginning of the lecture, B mode, it's displayed as a graphical representation here as a wave. With the upward wave here representing, this is a diaphragm. This is a scan line, focusing a scan line on the dome of the diaphragm or the area where we expect there is a maximal excursion or movement of the diaphragm. It's represented by a wave here. So with inspiration, the diaphragm descends in the abdominal cavity, as we all know. So it actually moves toward the probe, causing this upward deflection of the wave. And the opposite happens when during expiration at quiet breathing. So we can see from this graph the direction of the diaphragm, movement of the diaphragm, and whether it's normal or abnormal. Like if there is paradoxical movement in diaphragmatic paralysis, we can actually measure this amplitude, and we can measure, and here there's a time. So we can measure the time taken here to determine the velocity, although it's not a parameter that's commonly used. So the diaphragm ultrasound not only assess the diaphragm structure here, but it actually assesses the function. So the diaphragm can be assessed during quiet breathing, deep breathing, or during sniffing and coughing. So for the B mode, we capture the axial view. This is the patient position, should lie in supine position with the probe placed here along the anterior axillary line, usually at the 7th, 8th, or 9th intercostal space. And just to place your probe spanning between 2 ribs. And what you see here, we target for the zone of opposition, which is the zone of attachment of the diaphragm to the rib cage, okay? So this is the ultrasound image of the diaphragm in axial view, and you will see here with this proposition, skin and subcutaneous tissue. You can see a rib here, and you can see a part of the rib other side. And you can see this hypoechoic muscle, the intercostal, and then the diaphragm will appear as 3 layers. The internal layer here is a hypoechoic muscle, and then it's surrounded by 2 hyperechoic bold echogenic lines representing the diaphragmatic pleura and the peritoneal membrane. Sometimes we can see here a hyperechoic line inside the diaphragm. This is totally normal. It's just another appearance of the diaphragm. So what this axial view can tell us, we can measure the thickness here using the distance caliper, just measure the distance or the thickness of the diaphragm, and we can measure the depth. the distance between the skin and the diaphragm, to know the depth of the diaphragm. We can assess the echo texture, but it's actually not used. It's not that useful. And we can use it, as we have just said, to choose the optimum interspace. You want to choose a space which is away from the lung during needle EMG to be sure to avoid injury of the lung. So not just we measure the absolute thickness, but we measure the change in the thickness with inspiration. So here is the B mode of the ultrasound of the diaphragm. Here at quiet breathing, and you measure thickness, and then you allow the patient to deeply inspire. Ask him a deep inspiration, and then we'll see the lung encroaching the diaphragm and peeling off of the diaphragm, and there is here evident increase in the thickness of the diaphragm compared to this image. So we can measure the absolute thickness, which is the mean of the absolute thickness is 0.34 millimeter. But actually, most important is the degree of a change of thickness, because sometimes in thin patients, in normal individual, you can see a thickness lower than that, and it's totally normal for this patient. So they depend mainly on the other parameters like thickening fraction, thickening ratio, degree of thickening, to know how the thickness change with inspiration. And if it's normal, should increase at least 20% increase in the thickness is normal. Less than that indicate paralysis. So this is video for the normal diaphragm. You can see here, this is this muscle, this is the diaphragm here, normal movement, and you will see that it will increase in thickness in response to deep inspiration. Here it is. Can you notice the evident increase in thickness of the diaphragm with inspiration? So this is a normal appearance. This is compared to the paralyzed diaphragm. In case of paralysis, the diaphragm becomes thin and atrophic. This is a diaphragm here, like thin strip of muscle. It's really atrophic and thin. And if it's completely paralyzed, it will not thicken during inspiration. This is a video from a patient who was actually referred for EMG for suspected diaphragmatic paralysis after, I think, as I remember, post like gastroplasty operation or something like that for obesity. And here, the patient totally refused the idea of inserting a needle in his diaphragm, even if it's guided by ultrasound. So the only way that we can help the patients, also it's not optimum, EMG can show us neuropathic changes or something like that. But here, the ultrasound is really helpful. Can see the diaphragm is thin and atrophic, and it does not thicken at all. It does not change in thickness. So we know that this is atrophic, and actually it's really hard to insert a needle in such thin atrophic diaphragm without ultrasound guidance. So the other approach or the other mode that we can use to assess the diaphragm is using the M mode. And there are three approaches for M mode: the subcostal anterior approach, posterior approach, and the xiphoid or sternal approach used in the children. But the most common is the subcostal approach, where the probe is placed in the subcostal region, midway between the anterior axillary line and the midclavicular line. And after adjusting the B mode and choosing the scan line, this is the direction of the scan line here, single scan line at the point of maximal excursion or the dome of the diaphragm. And here we can see what the graph here. So again, this is direction of the diaphragm, and we can measure actually the amplitude of the excursion here through the y-axis, and we can actually see the time taken for this movement to happen. And from the distance at the time, velocity can be calculated also. Again, the velocity is not a useful parameter, but it just tell you how ultrasound can be used to assess the function of the diaphragm. So from this view, we can see the degree of excursion, and it's really, in the literature, it's really highly variable between 1.9 and 9 centimeter, and it's really wide range. We can calculate the velocity, and we can see the direction of excursion as well. And interesting application for this approach as well is to see the response to phrenic nerve stimulation. So if you are performing nerve conduction study for the phrenic nerve, and you want to be sure if the compound muscle action potential elicited actually arise from the diaphragm or just a volume conduction from the intercostal muscle. So you can use just the M mode, place the probe while stimulating the nerve and see. If there is a movement of the diaphragm, then this compound muscle action potential represents a diaphragmatic response. If not, you may have to adjust your probe to be able to capture or see to be able to capture the compound muscle action potential. So it's really, again, helpful to for us to optimize the nerve conduction, and we will see again for the EMG as well. So in case of diaphragmatic paralysis, you will not see this wave. You will see just a flat line here. No wave during deep breathing, nothing. And in cases of paralysis, sometimes there is a paradoxical diaphragmatic motion. So instead of the diaphragm moving down with inspiration, it actually moves up. So it moves away from the probe during expiration. And you will, instead of seeing this upward deflection, you will see a downward movement, downward direction of the wave. So it can help for in detection of the paradoxical diaphragmatic motion. So in conclusion, how can diaphragm ultrasound help us? Well, in cases of patient with a diaphragmatic weakness and you suspect that this weakness is due to a neuromuscular cause, it can help to differentiate between central and peripheral causes like phrenic neuropathy. So again, you stimulate the phrenic nerve, see the diaphragm movement using the ultrasound, and see. If it results in normal diaphragmatic motion, then this is a central cause. If no movement despite the phrenic stimulation, then suspect it's a phrenic neuropathy. It's really helpful in ALS patients to test if they are candidate for diaphragm pacemaker or not. So if the diaphragm is paralyzed, they are candidates for pacemaker. And it can help in the adjustment of the pacemaker. So you evaluate the patient during serial follow-up visit, and you evaluate the amplitude of the excursion as we have just seen in the M mode, and see if there is a good excursion, then you don't need adjustment. If it is not good, then you can adjust the pacemaker to achieve a better excursion. So the applications are actually numerous and it's really interesting. So you can use it as well if the patient has a neurogenic or peripheral or phrenic neuropathy, diaphragmatic paralysis with phrenic neuropathy, you can use for follow-up. So you can do serial measurements as well and see the increase in inspiratory thickness. So during serial visits, if you find the increase in the inspiratory thickness, then it correlates with the re-innervation after phrenic neuropathy. It's really, they use it in the ICU for critically ill patients to predict the success of weaning. So they just scan the diaphragm and see the degree of excursion while turning off the ventilator and trying spontaneous breathing. Then we'll see the degree of excursion and thickening fraction. If it's more than 25 millimeter, the excursion, and if the fraction order is more than 30-60%, then this predicts success of weaning. Can it help in muscle disease? Yes, it can help in muscle disease. It can be used to predict respiratory failure, and they have found actually that the diaphragmatic thickness is increased in Duchenne muscle dystrophy, similar to the pseudohypertrophy of the limb muscle. So we don't have enough data about that, but I think it can predict, yes, respiratory failure through the assessment of the diaphragmatic function. So the last two applications is again the use of the ultrasound to optimize the nerve conduction and EMG techniques. So to guide for phrenic nerve conduction, so you want to be sure that the elicited response actually reflects the diaphragmatic movement and it's not just volume conduction. And you can use, if you don't find, if you find diaphragmatic movement and if you are doing phrenic stimulation but you cannot see a response, you manipulate your proposition to be able to obtain this response. So it's really helpful for nerve conduction. You can use it as well to guide needle EMG, either during the needle insertion itself, real-time guidance using in-plane approach, or you can do it prior to EMG to know the depth of the diaphragm and how far you are going to go with the needle. And you can use it to choose the best interspace for needle insertion. As we have just mentioned, just choose an interspace away from the lung. So this is the picture for the in-plane approach for ultrasound guided EMG of the diaphragm to be sure that you are in the diaphragm. So this is as regards the diaphragm ultrasound. The last domain that we are going to talk, as I an interesting application for dynamic muscle ultrasound, which is to study the muscle architecture change. It's really interesting for those who work in the field of sports medicine and sport injury, and they want to study the change in the muscle biomechanics and muscle architecture in response to different types of sports or different type of sports injury, or in response to contraction or physiological contraction. So as we all know, the muscle force is actually affected by multiple factors, and one of these factors including the muscle architecture. So the muscle architecture and the muscle force depends on an important factor, which is a fiber arrangement. And the fiber, for example, here we all know that there are different arrangements for a muscle fiber in the muscle. It can be fusiform, it can be quadrilateral, it can be triangular, it can be pinnate muscle, bipinnate, unipinnate, or circumpinnate. And in pinnate muscle, it's actually generate more force than the fusiform muscle because of the large physiological cross-sectional area. So the pinnate muscle, the fibers are arranged up in an oblique plane in relation to the central aponeurosis of the muscle. So this muscle, pinnate muscle, is characterized by greater force and less lengthening or excursion. This is in contrast to the fusiform muscle, for example. So what we can see and what we can measure in ultrasound is the pennation angle. It's the angle between the muscle fiber and the central aponeurosis. And the pennation angle normally is 0 to 30 degrees. So this is the pennation angle, the angle between the direction of the muscle fiber and the aponeurosis or the internal tendon. And this pennation angle increased with muscle hypertrophy and increased during muscle contraction. So the ultrasound can be used to determine this pennation angle, and we can use it to study the dynamic change of this pennation angle during contraction or during sports or whatever reason you want. So we can measure as well, not just the pennation angle. So again, this is the pennation angle, the angle between the direction of the muscle fiber in pinnate muscle and the central tendon. And you can measure the fascicle length, this fascicle length here, this line. And you can measure the central aponeurosis length as well using the ultrasound. So these ultrasound image showing here the pennation angle, the angle between the muscle fiber and the deep aponeurosis. You can measure the muscle fascicle, and you can measure the muscle thickness and study this, the change in these parameters during contraction. So this is just shows you how the muscle pennation angle change. So this is at rest and this is during active contraction. And we measure this parameter in longitudinal view, and the muscle strength directly proportional to the cosine pennation angle. It correlates with the force regeneration as we have just mentioned, and so it can be used to study the response, how the muscle architecture change response to comparison between different types of sports or the change in response to muscle sport injury. You can measure as well other parameters like the cross-sectional area of the muscle, not just the pennation angle. You can measure the muscle thickness in the axial view or longitudinal view and see and compare them at rest versus muscle contraction. This is actually domain for research. Like a research domain is not, you don't use that in daily clinical practice. It's mainly an area for research if you are interested. There are actually trials as well to for automated detection of for pennation angle as well. So pennation angle can be calculated manually, but there are trials as well and research on developing methods for automated calculation of the pennation angle. You can search on that as well. So last thing I'm going to talk about, just to open the door for this and just to show that the applications of dynamic muscle ultrasound are actually endless. So it has been studied for its utility in the assessment of tongue movement in dysphagia. And we can use it as well in muscle hernia. For example, here, the muscle hernia is just herniation of the muscles and penetration of the muscle through a fascia. So this is the tibialis anterior, and this is the fascia covering the muscle. This is totally normal. Sometimes, in some athletes, there is a herniation of the muscle. there is a defect in the fascia and the muscle herniates through this. And sometimes you cannot see this herniation at rest. You have to do it dynamically. You have to ask the patient, for example, if tibialis anterior, the patient to squat to increase the pressure and provoke the appearance of this muscle hernia. You have just to take care that to release the pressure by the probe so as not to reduce this hernia and to improve its visibility. So it gives like a mushroom-like here appearance. So this is the tibialis anterior herniating through the fascia here. Another interesting application, this is a case, this is one of our patients. This was a study I have performed at Wake Forest when I was there. And our study was mainly on ultrasound of the facial nerve in Bell's palsy. And this is one of our patients in the study. This study was performed and conducted with Dr. Walker and Dr. Cartwright. And one of the patients, we thought just to scan this patient suspecting as having synkinesis. And you can use the M mode just to see the synkinesis. So this is the M mode of the orbicularis oris here. And this is the wave here generated. So you just put your probe here and you ask the patient to close the eye. And we can see here that this is actually, he's not contracting the orbicularis oris, contracting the orbicularis oculi. And we can see that there is a movement triggered in the orbicularis oculi with the movement of the eye. And we have, we're interested to see what we can see. So this is just one of the few applications we can use. If you know the concept, you can use the M mode and B mode to see different conditions. So just to conclude, dynamic muscle ultrasound is really an interesting domain. It has several applications. The most two applications that you can use in daily practice currently, ALS or muscle movement disorder, pathological, especially fasciculation. Diaphragm is really interesting for those who work in this field or in the ICUs or in cardiopulmonary branch. Research practice mainly venation angle, anatomical technique, and the muscle architecture is mainly a research practice. And don't forget the factors that affect the frame rate and the pitfalls and the technique that you should follow to be able to see the change in the muscle. And thank you for your attention, and sorry for the long lecture. So I will open the discussion now for any questions. Let me see the question and answer box. So we'll start with the questions on the previous lecture. So 3 challenging cases that we face in electrophysiology is thoracic outlet, neuralgia parathetica, and pyriform syndrome. Can ultrasound help? Well, it can help, but it's actually limited, especially in thoracic outlet and pyriforms. In thoracic outlet, it's not the best tool to assess the thoracic outlet. MRI is much better. We cannot see the C81 in many patients, really hard. And if you suspect this at the level of the cord infraclavicular, it's really hard to capture the effect. There are studies that have investigated the measurement of the cords in the infraclavicular region and the rest position and with the abduction of the shoulder, like similar to the Addison position, to see the change in the cross-sectional area. And some other studies have investigated like the thickness of the, for example, pectoralis minor. So sometimes there is a hypertrophy of the pectoralis minor that may compress the thoracic outlet. But actually it's not the best modality. It can confirm if there is a positive finding, but if it's negative finding, it does not exclude. So for neuralgia parathetica, I see it beneficial, as Professor Antonius has showed us, that we can see the lateral femoral cutaneous nerve. And if there is entrapment, sometimes you cannot see any change in the cross-sectional area, but you can measure the cross-sectional area, compare it with the other side. But I think ultrasound is more beneficial prior to doing nerve conduction. So sometimes there is anatomical variation in the position of the lateral femoral cutaneous nerve, whether it's medial to the anterior superior spine or lateral. So sometimes you just do the perfect nerve conduction technique and you cannot just see a response at all. Sometimes it may be due to anatomical variation in the position. You are stimulating medial to anterior spine, but actually the nerve is located lateral. So I think it's really beneficial. You can try to do it with the nerve conduction and pray. And most important, to do it before you do the nerve conduction, or if you cannot elicit a response from the typical position of electrodes in nerve conduction. As for the piriforms, again, it can confirm but does not exclude. It's really hard to see, especially in obese patients, it's really hard to see clearly the sciatic nerve and the piriforms muscle with a clear demarcation in this area. And I totally believe that the MRI is much better in this area as well. So the next question is, when infiltrate median nerve from the ulnar side, the most injury part? I think you mean if you adopt the ulnar approach for median nerve, like in carpal tunnel injection. I think the most is sometimes you can see injury in the anatomical variations in the thinner motor branch of the median nerve. Sometimes it crosses the medial side, sometimes really superficial, so it may be injured. Or if there is anatomical variation, the palmar cutaneous branch emerging from the ulnar side of the median nerve and continuing on the ulnar side of the median nerve, not on not toward the flexor carpi radialis tendon. I think other structures, I don't think they are liable to be injured during the ulnar approach. What about the suprascapular nerve? If you are talking about the utility of ultrasound to see the scapular nerve, yes, we can see it. This is a topic in the advanced course. We focus on these nerves like the axillary nerve and suprascapular in an advanced course. We can see the suprascapular nerve. We cannot trace it, of course, along the entire course, but we can capture the suprascapular nerve just in the supraspinatus fossa, and we can measure the cross-sectional area and compare it with the other sides. You can see portion of the suprascapular nerve along the neck in the interscalene region. But we can sometimes, if you cannot find the suprascapular nerve, it's hard to visualize, we use actually the muscle ultrasound and assess the ecotexture of the supraspinatus and infraspinatus and compare with the other side. If there is a suprascapular neuropathy, you will find that especially if it's chronic axonal, you will find the supraspinatus, according to the level of the region, you can find the supraspinatus and infraspinatus hyperechoic with a significant difference in muscle thickness on side-to-side comparison. Can palmar cutaneous branch of median nerve injured during hydrodissection? Well, it can be injured if you are not aware of its position and if you are using the lateral approach. So whether it's hydrodissection or injection or surgery, you have to, if you want really to be sure, just get away from it. Just you can scan before the procedure. When inject median nerve from the ulnar side, the most structure that can be injured, radial artery, I think. From the ulnar side, no, the radial artery is located on the lateral side, and the flexor pollicis longus as well is located inside the tunnel on the lateral aspect of the tunnel. So it's not liable to be injured from the ulnar side. Sensory branch of the ulnar nerve is quite away. There is a good distance between the median nerve and the ulnar aspect of the wrist. And the approach usually avoid this sensory branch. It can be, yes, palmar cutaneous branch can be injured if there is anatomical variations emerging from the ulnar side, not from the lateral side. I would like to ask if I scan the lamb subclavian fossa and find it's vascularized and hypoechoic, well-defined, adjacent to the internal carotid and jugular vein. I'm not sure what do you mean by the scanning the lamb. So can you clarify this question again for me? And I will get back to you. So for ultrasound of the diaphragm, it's better to use curvy linear or linear. For B mode, we use linear. For the M modes, it's used the curvy linear probe. The subcostal approach M mode use curvy linear. lecture is recorded. I hope that the whole webinar is recorded. Recording is actually automatically done by Zoom, so I don't interfere with it. Just automatic recording of the entire webinar, and I have to check it after downloading the recording if it's recorded or not. Sometimes we reach the limit of recording, so I hope it will be recorded. In Duchenne muscle dystrophy, the diaphragm muscle thickness will increase, but about the brightness. Well, I'm not aware of studies. Maybe I don't know of this. I'm not sure if the brightness differ, but you can compare. I think it can, in cases if it is like long-standing as in any muscle, the muscle may change architecture. But the evidence based regarding this point, I have to look at the literature to answer. The M mode wave, well, in M mode, if the diaphragm is weak, the amplitude of excursion will be lower than normal, or compare it with the, if it's hemi-diaphragm, compare it with the other side. Other questions to share? Great thing. Thank you all for the nice comments. Are there any questions? I think I have just addressed all the questions. I'm not sure, Telegram group to share webinar of courses. I'm not sure what is that. So I think we are done with questions. Does anyone have any questions else? So if you have any questions, yeah, I think you have my email address in the emails that you have received from Zoom. So I think we are done here. Sorry again for the delay in the schedule. It's out of our hands, but I didn't want to interrupt any speaker because I really think that the topics are really important and they deserve the delay, if you agree with me. So thank you for joining us, and thank you for staying with me till this time, starting from 8 a.m. and now it's 2:23. So thank you for joining us, and just a few remarks before I end the webinar. I'll just kindly ask you after you leave the webinar just to fill out the survey. It's really important for us. I'd like to know the feedbacks, and especially if are planning for future courses, either physical course or whatsoever, we'd like to know like your comments and any ideas. Secondly, if you are asking about the recording, I just kindly ask you just to wait for about 1 week. It really takes time from us to check the recording. And before we launch the webinar, we actually try our presentations and technical issues pre-opening the webinar. It's like a practice session. So we have to trim this practice session. We have to sometimes combine the recordings to obtain one video. So it really takes time. So I really ask you not to rush us because really we're hectic days. So we'll try our best to provide the recordings within 1 week after the course. If you are asking about a certificate, I'll be happy to send you a certificate of attendance. There are no credit points for this course, but I can send you an electronic format for attendance, certificate of attendance. Thank you. And if anyone has any comments or questions. So wish you a lovely day and a lovely weekend, and see you. Thank you so much. Oh, one more thing. I just forgot to tell you that Professor Natalie Winter and Professor Doris had to leave early this day, but they thank you all for your participation. They thank you for joining us, and they thank you for the questions that you have raised, because it actually allows the interaction between us and you, and it enriches the course definitely. So thank you again.